Hello, I'm Dr. Robert Holcomb, and we'd like to welcome you guys to the inaugural event of the pre-conference for the NICU Symposium, Hot Topics in Transport Medicine. We're very excited about what's going to happen today. We've got three wonderful speakers, and in this day and age where it seems like virtual conferences are taking over, we hope we're giving you something that you can watch in the own privacy of your home, in your office, or at work with your team members. I'd like to, first of all, thank the collaboration with International Biomedical, John Seegers and the group down in Austin, Texas, as well as the folks at HealthStar One, a branch of MedTrans Corporation. Together with HCA Midwest and our transport service, we are bringing you this pre-conference on transport medicine. As I said before, in this day and age of COVID, it seems like the venues and the atmospheres have changed for conferences. Seems like 2019 was the last big year where we saw conferences in transport medicine of upwards of 200 to 300 people. And since then, we've dwindled to a virtual format with the American Academy of Pediatric conferences, and even recently in Anaheim, we saw quite a few less than what we expected. I know my colleagues and friends in Utah also were seeing a decrease. I hope that as we start to recover from this day and age of COVID and the effect it's had on staffing as well as financial hardship, that we can see people more and more in person, because I truly feel from a transport medicine perspective that networking makes a huge difference. I want to thank the planning committee. There's a whole group of folks, you'll see them on these slides going around, who have been so instrumental in making the conference come to where it is today. If you guys were here in the room, you won't see it, but they've done a very nice job for our folks that are attending in person, and hopefully we'll be able to share this with you in the distant future as we go back to being live. The CME and CEUs are going to be available after the conference when you receive your evaluation. We ask that you fill out your evaluation and then turn it back in. And so at that point in time, then folks can claim their CEUs or CMEs. For those of you that are joining us here in the virtual format, there is a QR code that you can scan, or there's a website on the entry that Amy Reska can get, where you can put in your online sign-in roster so that we can make sure we get you those CEU or CME certificates. If for some reason you don't get an evaluation, you can certainly email Amy, and she'll be very happy to get that to you. I do want to emphasize that to get your CEUs or CMEs, you have to participate today live during this process, but we are going to have this material available for upwards of a year. And so if you'd like to share with your other team members, I know that in the transport community so many times we have people gather around a video and 5 or 6 or maybe even more watch when only one person registers. Not everybody will be able to get their medical education credits, but they can certainly gain from the knowledge that's going to be shared today by our three wonderful speakers. As we get ready to head off, there's a couple of housekeeping items here. I mentioned already about the QR code. When you do go in and you load up and the video comes up, it is in a muted format, so make sure you unmute it so that you can hear the speakers. You can expand at that point in time to full screen if you like. Questions will be coming through the chat room, and Caitlin's here. She's going to be writing down the questions and sending them over to me during our Q&A sessions. Anything is welcome as far as questions. The three speakers are wonderful, and as you guys have probably seen them in person, very approachable. So any question you have, let us know. So with that being said, let's move on to our first speaker. I want to go ahead and show the folks the fifth, we've got right here, the 4th edition of the Air and Ground Transports of Neonatal and Pediatric Patients. Is that showing up? Yep, good deal. So our first speaker is actually is involved in the 5th edition. I am currently the editor-in-chief for the 5th edition, and I'm hoping to have this out to you in 2024. We've got some exciting new chapters. We've got ones on high-risk OB, simulation, ECMO, and infectious disease in honor of, obviously, our recent COVID days. So hopefully the 5th edition will be coming out sooner. But I'm very, very happy and very proud to have Nikki Shimko come to us. She is a wonderful individual, wonderful speaker, and again, a co-author on the high-risk OB chapter that's going to be coming out in the new edition of the guidelines. Nikki has been a leader of the pediatric neonatal transport team for over 10 years and was responsible for expanding the care provided to include high-risk maternal transports. Nikki has over 23 years of professional nursing experience. She received her BSN from Syracuse University and MSN from Walden University. In 2019, the strategic plan to regionalize perinatal care in the area brought on new challenges for the transport team, creating the development and implementation of the high-risk maternal transport team. Nikki's responsibilities include overseeing all aspects of the team development, administration, research, clinical education, performance improvement, and ongoing evaluation. Nikki is the current president of the Florida Neonatal Pediatric Transport Network Association and a board member of the Florida Association of Critical Care Transport Specialists. She is also a Florida EMS for Children Advisory Council committee member, and she has developed on topics that include the development of the maternal transport team, pediatric special needs, and hurricane evacuation. And just so you know, in addition to high-risk OB, which is a very young field, part of our field, and probably the youngest of all our teams, she was also intimately involved with the recent hurricane that took a lot of folks out of homes in Florida, and obviously some lives as well. So we're very happy and very honored to have Nikki come and talk to us now about high-risk OB transport.
Hello, everybody. Thank you for joining. I am so excited to be here with you guys today. I love the one thing that COVID did for us was give us this Zoom feature or, recording feature that we never had. The downfall is I'm a people person. So this is very hard for me to talk and not be able to interact with you all. So I'm going to do my best, but I'm happy to be here to share all this information I have for you guys today. I have no financial disclosures and no conflict of interest in anything presented in this presentation. So my name is Nikki Shimko. I am a manager of the Neo Pediatric and High Risk Maternal Transport team down here at Golisano Children's Hospital in Fort Myers, Florida. I've been in the transport avenue for over 10 years now. My background is I started in PICU and then learned the NICU side of it, and now have really incorporated the high risk OB into my realm. We started our team in 2019 and have really enjoyed all this aspect of nursing and healthcare that I never anticipated enjoying. So today we're going to talk about the transport team of high-risk OB patients, the role of the maternal transport team, and then understanding some common pregnancy complications during the care of transport. So nationally, we are starting to see, and I know significantly down here in Florida, we are our rural, yeah, say that 10 times fast. Hospitals are closing their OB services. And transport times of these maternal high-risk moms has increased. Studies show that, decrease in access to these services create out-of-hospital births, non-OB hospital births, preterm births, and create a problem with lack of prenatal care. So transferring these moms to higher level of cares or appropriate level of cares, the question is, who's doing those transports? So think about that in your area. Who is doing those transports? This isn't a new topic. Back in the 70s, the discussion of transports for high-risk newborns and the survival of transporting moms was studied, and these are a couple that were published. So the whys of having a maternal transport team, they do provide that specialized care and that increased skill set. You can make it up in very different avenues. It could be a critical care team that does have OB specialty. You could throw an OB nurse onto your team and incorporate your NICU team as well. It's kind of about your resources and what you have available. What we have found is OB really shares that realm of specialty, just like the neonatal and pediatric population. The ERs are scared of the OB patients, just like they're scared of the pediatric patients. So having this specialized care coming to them really kind of helps ease the fear of a lot of people. So the biggest question is, when they go to a non-OB facility, who's assessing in that ED or in that area? Who's assessing that mom? Are they assessing appropriately? Do they have the resources to assess that mom appropriately? What equipment do they have at that facility? And then you're talking about to transport or not. So things that we would go and assess our maternal vital signs. How dilated are they? What's the effacement? What's the length of transport to getting to the end facility, to the proper care? What resources are available to them, and what are the needs of the infants? So there's so much that goes into where this mom can transport to, and what's the best place for her. And then during transport, the discussion and conversation is, what resources will you have in the ambulance? What personnel will you have? What equipment will you have? What interventions could you really do in the ambulance? So when we start to talk about complications as we go through it, we'll look at, should we transport or not transport? Should we deliver where we're at? Should we move them? It's always going to be a case-by-case situation. So let's talk about a few maternal complications. And I do have some case reviews that we will present to kind of make this a little bit more, I guess, interactive, if you could say. First, we have pregnancy-induced hypertension. There's the definition. Obviously, sustained blood pressure. This is an onset due to pregnancy, and it usually manifests after about 20 weeks of gestation, resolved by 6 weeks of postpartum. It does account for 6.8% of the pregnancy-related maternal deaths, and it can affect anywhere from 5 to 10% of the pregnancies. So the difference is, you can throw this mom in the ambulance. Is she going to get treated the right way? And so with all of these moms, the treatment, always starts with ABCs. So let's, make sure we're treating the basics first. We're going to position these moms on her left side, get her off the pressure, displace the uterus a little bit off of your vena cava, helping decrease some of that blood pressure. Also, there's medications that we can give, and I don't need to read these to you, but these are the 3 main medications that are used to treat pregnancy-induced hypertension. So of these medications, do our local agencies have any of these that they carry? I don't know the answer. And are they able to continue to assess? So, and then, obviously looking at labetalol and your contraindications. So you would choose one, and then you could repeat doses, and then you're going to talk to medical control if it's not continuing to decrease her blood pressure. As soon as your blood pressure drops under 160 over 110, you do want to continue to monitor your blood pressure for every 10 minutes for an hour. I can tell you that doesn't happen frequently on a lot of ambulances. And you want to avoid dropping the diastolic blood pressure less than 90. And then you want to monitor for seizures, high blood pressure, increased ICP, irritability. So let's talk about seizures. This is eclamptic seizures. So this is due to that high blood pressure and due to pregnancy. And it can happen at any point in time in the pregnancy, but it really is associated also with that high blood pressure that's usually after the 20 weeks of gestation. It is a medical emergency, and it is associated with morbidity and mortality of the mother and the fetus. Again, for treatment for this, you're going to do your ABCs, your high flow face mask, 10 to 15 liters on a face mask on the left side again. And then the medication for this one, it's MAG. You want to give 4 grams IV times 30 minutes. And it can be used to prevent seizures as well. So you can give it before she has a seizure or immediately as a seizure is happening. And then you're going to continue with an infusion. You can give Ativan as well. I don't really want to read all the slides to you. What you want to watch for, though, with magnesium is your toxicity. So your absent reflexes, your respiratory, your cardiac depression. You want to stop that in MAG immediately and then give calcium gluconate. And I kind of repeated it here, but if you have any respiratory depression or respiratory arrest, you really are going to stop it. Give the calcium gluconate and figure out what you need to do for an airway aspect. Mom's airway is important to keep the baby alive too. So then we get into premature rupture of membranes. This is the premature rupture of membranes is prior to 37 weeks of gestation. And again, ABCs, left lateral side. And this is also to decrease that pressure on the cervix for many presenting parts and hopefully not delivering. You definitely want to avoid vaginal exams on these unless the birth is imminent or there is some fetal bradycardia. Continue any antibiotics that may have been started and be prepared for potential delivery. So let's talk about a case. I'm actually going to take a quick sip of water. Hold on. I'll give everybody a little break here. So we had a mother show up at a non-OB facility, 27 weeks gestation, at a referring facility that was 35 minutes away. The notification was abdominal pain. The transport team departed, obtains report on the way, so we're like, okay, abdominal pain, 27 weeks, who knows what's really happening. And then during report, the MTT does receive information that the membranes were ruptured. So upon arrival to assessing the mother, there's no TOCO monitor over there at this facility. All they had was Doppler for fetal heart rate. And so this, the MTT, who on our case is an OB-RN that we throw on the ambulance with us or have them ride with us, and the NICU team. So there actually is 2 RNs, an RT, and then a medic. So this OB nurse that we have on our team did the exam and realized that the cord was prolapsed from the ruptured membranes as well. So here's a vision of what a prolapsed cord would look like. So she could actually feel the pulse in the cord, knew it was the cord. And on the way from transport, so the 35-minute ride, she actually held pressure and held that cord in and continued to prevent it from prolapsing more. And she could feel the heart rate and the pulse in the cord, and she rode in the ambulance that way. They directly went straight to OR from the ambulance, where she had a C-section, and the mother and baby both survived. The baby was admitted to NICU for about a week and then discharged with no complications. So it's kind of one of those cases that I say that OB nurse saved that mom and baby's life, or especially the baby's life. And these are the reasons that the maternal transport team becomes so important in the complex care of these patients. That nurse actually ended up having a wrist injury afterwards and was out of work for a little bit, but she is back to work and doing fine. So then we talk about preterm labor. ABCs, is the mother dehydrated? Do we need to start medications to stop contractions? How early is it? What kind of contractions? How often? And then, so we have options of terbutaline and we have options of MAG. So our case study for this one was 36 weeks, Gravida 6. So 36 weeks is kind of close for the cutoff of preterm, but it's still considered preterm, 37 weeks and under. The report that we received was the patient had been in labor for a while. The ED had not examined the mother yet, which we frequently find before, and they just call us. The OB physician states she does not want the baby to be delivered in the ambulance. So Gravida 6, 36 weeks, we figure that baby could pop out at any point in time. So ED finally checks the patient, states, oh, she's at 4 and 25% effaced. Finally, the transport team is notified. They depart in 17 minutes. Transport team arrives 22 minutes later to check mom. At this point in time, she is 9 centimeters, 0% effaced. So originally the transport team had thought, we'll get there, we'll be able to bring her back. However, when they got there, they assessed, they did the math with the timing. They really kind of looked to see how long the transport was. Do they have the resources at the facility where they were at? So they did decide to deliver there. And the ruptured membranes were about 28 minutes later. They were able to, get the infant warmer ready for the neonate. Mom did deliver 13 minutes later, both stabilized and transferred to the OB and neo facility, both with great outcomes. But again, it speaks to that original, assessing your resources at the facility you have and the risks and the benefits and outweighing them. So then the other complication of pregnancy is bleeding. So an undelivered bleeding leads to, potentially traumatic outcomes. Again, doing your ABCs, checking the fetal heart rate, IV fluids, and then blood products as your medical control or the ED that the patient is at. No vaginal exams on these patients unless there is imminent delivery. And, I'm going to go back for a second because I say imminent delivery, and this becomes one of those hot topics. There's really not a huge true definition of imminent delivery if you look out there, except for, crowning, pushing. So it's very hard in non-OB facilities to get a true assessment of really imminent delivery unless the baby is truly crowning. So this case review is, I did put times on here just to kind of, break it up a little bit and tell you, but 26 weeks gestation. So premature, arrives to a non-OB ED, and they called to connect transfer center with OB hospitalist and transfer center. And the information that was given was contracting every 2 minutes, decreased fetal movement, gravida 4 prior to, pain just like last time. Baby looks good on ultrasound, cervix closed, getting labs. BP was 113 over 96. OB says, okay, send her to OB ED. So unfortunately on this case, and we'll go back a minute here. So it all started at 9:15. 45 minutes later, the calls get to the transport team. And at this point in time, the transport team is already out on two other calls. So they defer to the local agency, who can't really be there till 11:15. So, at this point in time, okay, well, the mom's stable. There's nothing truly showing true emergent. There is a backup. We could call EMS if we needed to. So at 10:15, ultrasound is at bedside. So they're doing their measurements. They're looking at the baby while they're waiting for the mom to be picked up. An hour later, the ambulance is there to pick up mom. A report is called to the OB hospitalist from the ultrasound saying unable to rule out indeterminate placenta abruption. By the time the mom arrives to the OB ED, the mom goes straight to the OR. Mother did have a C-section. It actually was a fetal demise at the end. So even in this, we say what was kind of missed in this assessment. When we look back at this case, there were a lot of things that we felt could have been done a little differently, in the sense that very first conversation, pain just like last time. So that was given in report to the OB hospitalist. You hear that and you think, okay, she's had other deliveries, so she's contracting. This is the pain she feels. What was not mentioned was she actually had a previous abruption, and this was the pain she was describing. So in that initial phone call, had some of that conversation really assessment-wise, discussion-wise, been described, this may have looked very different in the outcome. So it goes back to those assessment skills and having that conversation. And with this placenta abruption, I did put it under bleeding. but nowhere in her assessment was there bleeding. So this ended up being a high abruption and no bleeding. But then we will talk about this case. So 7-month-old gestation pregnancy, vaginal bleeding. Transport team was notified and said, please go urgently. They're basically freaking out and need the team. History obtained, vaginal bleeding for 2 days, no prenatal care. But oh, by the way, her hemoglobin's 3.9. Okay. Yep, let's go. We're going to go get the mom. We're going to bring her back to the OB hospital ASAP. So as we arrive there, the mother is being intubated because she is crashing, and PRBCs are infusing. The transport team arrives in 21 minutes, gets to the crashing mom, assessment of the OB nurse from the maternal transport team, the ED/MD, and then with the OB medical control on the phone, the discussion was they needed to do an urgent C-section at the bedside in the ED. So luckily, again, our team is made up of the NICU team plus the maternal transport nurse. So in this case, our maternal transport nurse, who does rotate in ORs and who does a lot of deliveries, walked this ED medical or ED/MD through the C-section and through the procedure, step by step, kind of holding hands, kind of really walking her through it. It was actually pretty incredible. The outcome for this case was the maternal nurse post that C-section actually held pressure on the mom's uterus to help prevent any more bleeding, and they rushed her up to the OR where the OB arrived to close her up. She was admitted for an ICU night at that facility and then transferred to the OB facility the next day. She has been discharged and is doing well. Luckily, with this case, the NICU team was there. So, they didn't go thinking they were going to deliver a 30-week baby. However, it changed and they had all their equipment. So they were able to deliver the 30-week baby. The baby did come out crying, was stable, needed stimulation, some CPAP. But in the end was transported to our NICU, admitted for 3 days, and discharged home and healthy. So it speaks to, again, having that capability to do some of this at outlying facilities, bringing those resources to them. Mom nor baby would have made it to the OB hospital at that point in time. And then there's trauma. This, will vary by obviously trauma facilities and, what your protocols are for your OB traumas on call and that. But a trauma in pregnancy is a trauma no matter how minor. And again, your ABCs, your IV fluids, for any kind of trauma, you want to avoid hypovolemia, especially for the fetus too. You don't want the blood shunting to the maternal organs and compromising the fetus. If there's uncontrolled bleeding, you want to try to, get that under control. And as in this last story, you may have to do an emergency section. The standard for trauma in pregnancy is to monitor them 4 hours post-trauma on continuous monitor. So another case review, and I hope these are helpful and kind of, help you think about some things. 30-week gestation mom who was an MVC. The airbag did deploy. She was the driver, and that was the time of the accident, was 3:34. She did arrive to the trauma unit at 4:20. Her heart rate was 108.
Good afternoon.
Review, and I hope these are helpful and kind of help you think about some things. 30-week gestation mom who was an MVC. The airbag did deploy. She was the driver, And that was the time of the accident, was 3:34. She did arrive to the trauma unit at 4:20. Her heart rate was 108 to 120s, and the fetal heart rate was 144. By 6:30, which is 10 minutes later, trauma had cleared her. From a trauma standpoint on the mom, they had assessed the fetal heart rate. However, OB trauma had not assessed her at that point in time just yet. So transport team was notified. So they go on their way. Ultrasound and Toko are finally at the bedside. The heart rate was 144. She does complain of back pain and discomfort. Is it contractions? Is it pain from the accident? Who knew at that point in time? However, the Toko monitor, we find that not all EDs obviously are the same either. And so really kind of understanding and being able to assess what's happening on that Toko monitor. Is she contracting? Are there D cells? What does that look like? So once the ultrasound report came back, the fetal heart rate was 92. So, okay, the baby, yes, is having some D cells. By the time maternal transport team arrives, they talk, they assess, yes, there's some D cells. However, they're not consistent and they're infrequent. So the decision was to transport mom emergently. They did Doppler the baby's heart rate the whole way in the ambulance, and it was 144. The patient arrived to the facility and did deliver via C-section. APGARs were 3, 4, and 7. So it really, sometimes you can always hindsight 2020, right? You can sit here and guess, should we have delivered over there emergently? Should we have not? Those are kind of questions you have to really make in your assessment at the time. So then there's a case of, what if they're not cleared by trauma? What if they can't be transferred to OB? What does that look like? We actually just had a recent case where it was a 23-week gestation. The mom was not cleared by trauma due to her injuries of fractures, pulmonary contusion, bruises, broken ribs. So this became a different scenario because they really didn't contact the transport team to transport the mom. But what they contacted for was they couldn't get her on the Toko monitor. She was 23 weeks. So was it because she was lower in gestation? Was it their skills of the Toko? The maternal transport nurse arrived to help assist because it was one of our local hospitals about 15 minutes away, and arrived to the mom having a full bladder. There was no Foley. So she quickly put a Foley in, decreased the bladder, got the baby and mom on Toko monitor. And yes, she was contracting every 2 minutes. And the heart rate was in the 80s consistently. So at this point in time, they decided to do emergency section there in the trauma OR. The baby was delivered and resuscitated, but did not make it from the abruption and the prolonged. What I didn't mention in this was there was an hour-long extrication as well for this mom. So there was a delay in getting her to the trauma center. So the question becomes, how do you use some of these resources? When do you use some of these resources? Could she have been sent to the OB area first and then transferred back for ortho? There's a lot of kind of questions, like I said, hindsight 2020, but it kind of brings up different scenarios to really think about. So I hope some of these stories helped you understand the real importance of having maternal transport. I really have found that it fits so well with the NEO and PD team, and just being able to provide that specialized care to these moms and then the NEOs if they need it. And yes, that is one of my children. This is the inside of one of our ambulances. We actually remounted one of our ambulances and reconfigured the flooring to allow for the stretcher and isolette. And now we have built a couple of new ambulances with 2 stretchers. So I always say the way to get started is to quit talking about it and begin doing. And that's a Walt Disney quote, because it was in the middle of this remount that we said, let's do this. And it has allowed us to provide these services that we never thought we could. Here are references that I used for this talk. And my email, if any of you have, and I know I'll be on here for some questions and answers. So I hope this presentation really gave you some information and showed you all the benefits of having a maternal transport team. Thank you so much.
Hey, Nikki, thank you so much.
Thanks for having me. I appreciate it.
Absolutely.
That was fun.
Well, we really enjoyed the presentation. That was wonderful. We've got a slew of questions here, but first and foremost,
oh, great.
yeah, well, we'll come in a little bit light. That way you don't get swamped with too many hard ones. I had a question. Do you want to just briefly go over some of the content that you have in your brand new chapter on maternal high-risk OB? There's such a young field, and there's so many teams now that are starting to put together high-risk OB transport teams that any guidance at all they can get is definitely looking forward to it. Can you give us a little glimpse of what's going to be in that chapter?
Absolutely. There was a handful of us that wrote this chapter, and it speaks to some of the differences of how to compile and make up a maternal transport team. There is examples of protocols in there. There is examples of treatments and really kind of looking at some of the whys, providing the whys to leadership and really helping you balance how to develop this. It talks about QA, things to look at as far as maternal transports. We all have our own things that we look at as far as QA, QI processes for a normal transport team, but what does that include for your maternal aspect of it as well? And then safety features. What kind of equipment do you need on the ambulance for this population? Did I forget anything in that chapter?
No, you covered it. I know there's a few vignettes in there too about some of these more common entities that we see in the clinical world. And having read that chapter myself, but I wanted them to hear it from you directly. It's going to be exciting. Well, let's jump in.
It was a great, fun challenge.
Yeah. Well, you and Mary and Amy did a wonderful job. So let's jump right in. This question's should be a pretty easy one to help you out with. What type of training do you require for your high-risk OB transport teams?
So we require at least 3 years of OB experience. They really have already been in charge, so they can kind of handle the day-to-day challenges that they face. They've had to have OR experience as well, so they've had to circulate through the OR and obviously deliveries and all of that.
Do you guys have a formal course, or what kind of training do you start them off with to get them ready for the atmosphere of transport?
They participate in our transport course that we offer. We do go over safety regulations with them, and we do a safety course with them as far as the ambulance. Most of their OB training, though, is still handled by the OB team and the OB educators.
Awesome. I think for a lot of the folks out there, understanding that there's the clinical side of things and the operational side of things, so much of what we do in transport medicine from a critical care transport standpoint overlaps as far as the operational side is concerned. And so knowing that operational side, the safety of the aircraft, and going through those training, as you mentioned, in formal courses is so important. But then, like you said, resources like your MFMs and such that help develop your clinical protocols.
Absolutely.
Okay. Have you ever had an emergency room provider step away once you arrive because they're uncomfortable, and how would you handle that?
Always. I would say that is no different on the maternal side than it is on the neo and pediatric side. We walk in and they're like, okay, great, we're done, thanks. And For the most part, you just have to bring them back in and say, we're partners in this care right now. Please help us. And, we'll get whoever we need to on the phone as far as a resource. Some of our EDs have, Caregility or iPads so that we could pull a NEO on the phone if we needed to for their resource. But it's really reminding them that they're still a partner in this care and bringing them back to it with us.
I think what some people need to understand is the medical legal responsibility is still theirs until you actually depart from that facility. Yeah. So if they abandon you, they're pretty much leaving everything wide open. One of the more difficult things that come up, and I remember when we first started talking to our maternal transport team members before we actually got them trained and going, was the what if they deliver on transport scenario. I noticed that you guys have a combination team when you deploy, but a lot of teams don't. Do you want to go over the feasibility of even just adding a person to complement the maternal team? Is that really worth it, or do you really gain much by that since you don't have the supplies and equipment?
I think that the answer to that question is going back to that original assessment and what you just said. What supplies and equipment do you have? Throwing another person on the ambulance from that ED may help if that's the case, because then somebody could help resuscitate an infant. I think, there's things, if they deliver, there's natural things as far as warming the baby, keeping the baby on mom's chest, keeping the baby warm if they're doing okay. Or there's always the option of pulling over and calling for more help.
Absolutely. Now, you guys have a dual team that both neonatal and high risk as well? Okay.
Yes. And we have occasionally when our truck is down and we don't have the capability of taking both teams, we will take the maternal nurse over first. And if they have to deliver, then we'll follow back up with the another truck with the isolette.
So deploying both
teams. But
teams.
for the most part,
Sure. What do you find to be the biggest challenge when determining if the OB patient is the almighty word stable? And I guess, I would add to that, the specialty transport teams, if all these patients were stable, probably the EMS community could do a lot of the transports. But the expectation, and by definition, the reason we send specialty transport teams is because they're just stabilized and they can become unstable at any point in time during the transport. What's your biggest challenge to determine that almighty word stable?
I think it's ensuring that those that are doing the assessment have that experience to say and not question their decision either, and follow their gut. They see it on a day-to-day basis. I think stable and imminent delivery are two words that I don't think anyone can ever truly define. And I think each case is going to bring its challenges for it. And I think everyone just has to realize that they're making the best decision they can. If that ER that has that patient isn't capable of taking care of them, then they're going to be better off getting in that ambulance and moving. I had somebody once say that this patient's going to die in our ER. They're going to die if you don't move them. So we need to move them. So at some point you have a heart rate and you have a blood pressure and you have to move them.
No, you're absolutely correct. And I know that we have encountered that as well, a scenario with a ER that had a non-OB services. And the question was, what do you do with the mom? And it's like, well, you need to run her to a place that has OB services. But when that was not feasible, what ended up happening instead was the deployment of both teams. At first, the maternal team, so we can get an accurate assessment. And it's hard for folks that don't do this on a day-to-day basis, trying to give you an accurate assessment to know exactly whether or not there's going to be an imminent delivery or whether or not the mom is stable. Do you guys use continuous fetal monitoring as part of your transport?
We do not, and that's a great question. It was a big conversation we had when actually writing the chapter for the standard of the book, and we did not put that in there as a standard. The artifact that is found in an ambulance with the continuous fetal monitoring, there's just no 100% reliability. We Doppler, or you have the ability to just ultrasound for the heart rate. The other thing is, if you're fetal monitoring with a monitor, there's not much you can do about it if she's not actually actively delivering. It's not like you're going to perform a C-section in the middle of an ambulance. So depending on time. So that's kind of the stance we took on the chapter as well.
Yeah. And I'm not familiar as far as fetal monitoring in the Rotary environment. Is that an approval by the FAA or not?
I don't know the answer to that question.
Yeah.
Jan says yes, it is.
Jan's
Thanks,
on.
Jan.
I didn't know if it.
Jan's on. She says yes, it is. I'm like, I don't know.
Okay, good. I didn't know if it was a particular brand that you had to use, or if all the brands are acceptable.
She's saying all brands are acceptable.
All right. Well, she's anxious to get up here, isn't she?
I know. She's a phone a friend. I love this. This is amazing.
No, this is awesome. As many of y'all are aware, having probably seen several of us already at various venues, Transport community is a small community, and we look out for our own. So it's not unusual then to get in these formats and find some of our colleagues and friends joining in, and that's what I mean by networking. So hopefully we'll get to the point where we're back in person again and have these kinds of networking opportunities. Okay, how big of a challenge has it been working with local EMS agencies that may look at transport team poaching of their territory? And that's actually a really interesting question. We've actually ran into it here in Kansas City, whereby it's actually a city ordinance. Then we have to get a special approval from the city manager to allow us to do those transports because that's taking money from the city. This is an expectation that, well, wait a minute here, we get HIROB training, so why can't we just do it and save it ourselves? What are you offering that they aren't offering? And so this is certainly one of the tougher questions, so saved it for one of the ones towards the end. But what do you think, Nikki?
Yeah, that is a great question. I will say I am in a community that is very lucky in the sense that EMS kind of stepped out of interfacility transports and handed it over to us as a PEDS NEO team, and then to private agencies. So it was really kind of talking with the private agencies about it, and their fear factor of those moms was just enough as the NEOs and the PEDS to say, please take them. It's okay. We really don't want to do these. And their volume was compensated in other ways with, the increase in mental health. And so they have not seen a decrease in their volume. So financially, it wasn't an impact for them. We do, however, I will say that one call that I mentioned that, we were out on back-to-back calls. This is the challenge because now they are our backup for these patients. So now they're not doing them as frequently. So how do you continue to provide that education for that staff to keep those up? Because if we're out and we're too busy, now we've taken away their frequency of these patients and keeping that education and that skill set up for them.
Yeah, and I really appreciated the vignette that you showed. It certainly did address those kinds of issues for sure. How many elevated blood pressures are required before delivery is recommended? Might be a judgment
This
call.
is my non-OB experience coming out here right now. Yeah, I'm going to say that. I'm going to have to defer that to your OB specialty, and really discuss what that looks like and the signs and symptoms for the mom.
I would probably say one more than the number you get when you're on transport, right?
Yes, yes. Or more than the two that you get on transport.
That's right. So if you only do two, you need to have three.
Yeah.
So I got the worldly experience of Hurricane Katrina way back when. In fact, you might say that it washed me ashore in Kansas. So many people saying, what are you doing? You're coming to Kansas, there's tornadoes. And it's like, well, those are only a half mile wide. Hurricanes are 100 miles wide. Can you share with us some of your experiences that happened? We missed you in Anaheim, but I know you guys were doing some great work. Can you tell us some of those experiences?
Oh, sure. Hurricane Ian was one to put down in the memory books, that's for sure. As kind of mentioned in the beginning, that I am the president of the Florida NEOPD Transport Association. So back in 2015 with Irma, we had developed a disaster response plan for NEOs and PEDS in the state of Florida, where we really all came together and said, if there is ever an evacuating need for NEOs and PDs, that we would all just jump in and do it. Because we know that these neonates require that specialized care. So after Hurricane Ian, we at Golisano here in Fort Myers lost water pressure at the hospital. And we couldn't put out fires. We couldn't we couldn't wash our hands at that point in time. Like we were really on alcohol gel. We still had power. We still had generator power because our generator had been built up. We didn't flood. It literally truly was just the lack of water resources. And ACA came in and said, you have to evacuate. So we ended up evacuating the whole Children's Hospital in 36 hours. 62 of those were NICU patients. And I would say my biggest takeaway from all of that, our total patients were 81 patients that we evacuated in 36 hours. Of those 62 neonates, we moved them to about 15 different facilities across the state. The closest one being 45 minutes only took 8. The rest of them were over 2 hours that we had to evacuate them. With the hurricane itself, the weather still held over us and up north. So flight in the very beginning wasn't much of an option unless they were coming from the East Coast down south. So it really was 7, 8 neo-peds teams driving their ambulances, coming and helping us evacuate these patients. And to me, I think the biggest takeaway was some of the triage aspect of it. We hear disasters, we think about evacuations, we're like, get the sick out first, get everybody out. This was a controlled chaos situation because we still had power, we still had a building that was standing. We just really needed to get them out, and let's get them out safely. So we deployed all the teams. We were all in texting communication, and triaging them from who could go to a level 2, who needed to go to a level 3, who had to go in an isolate, because now we only have a handful of isolates from the state around the area because the FEMA ambulances only have the stretchers. So who was in the open crib, who was going to the level 2, who could sustain for over 2 hours on that stretcher and not be in an isolate. So those challenges really came out, but the teams all came together, and really there were no adverse events. Everyone arrived at the hospital the way they were supposed to. So I always say, people talk about disasters and drilling. If you've ever had an opportunity to move a hospital, that was our drill, because we moved into our new hospital about 5 years ago, and the two-way communication with radios and just some of the tactics we used during that move, we really put into place during the evacuation.
It's incredible, just incredible. No, it's mass casualties is always a very tough thing as far as and the coordination, putting it together, and all the practice in the world, can get you prepared, but not until it actually hits the front of the face. You actually truly realize and appreciate what you're dealing with. Yes. Was there any questions
we
from
opened
our
back
audience?
up.
Oh, go ahead, Nikki, I'm sorry.
I was just going to say, we opened back up about 2 weeks later, and we ended up bringing 33 babies back. And I would say that's the part of the disaster plan that's really not written, and that what we really kind of wrote was, how do we do this? What does this look like? So we ended up having a triage for those families, as well as who wanted to come back, who had the resources to come back, what facilities were at capacity that needed to offload some of those patients that they took from us, and then who really needed to come back to our care too.
Absolutely, absolutely. Anybody in our audience have any questions that they have for Nikki? No? Okay. Well, Nikki, we certainly have appreciated having you. Thank you so much. This was a wonderful event. I hope we can get together in the near future here in person and quit doing these things over virtual.
I agree completely. I am that people person in networking, and that's the biggest success of the evacuation. It's the relationships we had all built.
Oh, absolutely. Absolutely. So we're kind of right now sitting with a little bit of extra time on our hands, even though we do know that Jan is on the line. It's been confirmed we have a Jan sighting. But let's go ahead and take a 20-minute break here, folks, and then we'll have everybody come back. Why don't we just say, let's bring everybody back at 2:05, and that way then we can get things set up in time for Jan and get her prepared and stuff. So we'll see you guys back here at 5 minutes after 2. All right. Huh? All your questions?
I know, and I texted out here.
Through every little raindrop and sky of blue, oh, how my heart beats for you. Past every little whistle stop and avenue, oh, how my heart beats for you. You are my shining star, no matter where you are. You're every rhyme that I have in my repertoire, and you are the reason why I'm never blue. Oh, how my heart beats for you. Every little whistle stop and avenue, oh, how my heart beats for you. You are my shining star, no matter where you are. You're every rhyme that I have in my repertoire, and you are the reason why I'm never blue. Oh, how my heart beats for you. Yeah. Here's something that I'd like to bring to you, wrapped all in cellophane, designed for you. A 2, 3, 4. Tell you what it's all about. It is without a doubt swinging in the latest style. Service with a smile. If you want to swing and shout, get your kicks and get about. I'm an errand boy of rhythm. Send me. Well, lace your boots and follow through. I'll deliver straight to you. I'm an errand boy for rhythm. Send me. Well, you can always find me down at Smokey Joe's. That's the place where every gal and gator goes. If you want variety, just step in and call for me. I'm an errand boy for rhythm. Send me. can always find me down at Smokey Joe's. Yeah, that's the place where every gal and gator goes. So if you want variety, just step in and call me. I'm an errand boy of rhythm. I'm an errand boy of rhythm, send me. A shadow across the blue Miami sky as we hit the causeway by the big hotels. We fought, now I can't remember why. After all the words were said and tears were gone, we vowed we'd never say goodbye. When we kissed, we could hear the sound of thunder as we watched the regulars rush the big hotels. We kissed again, and as the showers swept that Florida shore, you opened your umbrella, and we walked between the raindrops back to your door. We walked between the raindrops back to your door. In my dreams, I can hear the sound of thunder. I can see the causeway by the big hotels. That happy day, we'll find each other on that Florida shore. You'll open your umbrella and we'll walk between the raindrops. Walk between the raindrops. We'll walk between the raindrops back to your door. walk between the raindrops back to your door, back to your door, back to your door. Baubles, bangles, hear how they jing-a-ling-a. Baubles, bangles, bright shiny beads, sparkles, spangles, your heart will sing, sing-a-ling-a. Wearing baubles, bangles, and beads, you'll glitter and gleam so. Make somebody dream so that someday he may buy you a ring, ring-a-ling-a. I've heard that's where it leads. Wearing baubles, bangles, and beads.
Hello and welcome back. We're once again at the Neonatal Education Symposium, Controversies and Standards of Care, and this is the pre-conference, Hot Topics in Transport Medicine. I want to welcome everybody back. We've got still two more exciting speakers, which we're very excited and think you're going to enjoy quite a bit hearing from both of them. Before I introduce our next speaker, I just want to make another shout out to our sponsors, for which this would not be possible. The pre-conference, we've worked in collaboration with HealthStar One, a branch of MedTrans Corporation, as well as International Biomedical and all the good folks down in Austin. We also want to put out a great thank you to Mead Johnson, to Prolacta, to Abbott Nutrition, and to Philips. Again, this would not be possible without their sponsorship. The folks had mentioned to me that on the website, on the video, that the pushing the chat button, they didn't get into a chat room. You actually have to push the chat button and then actually register your name there so we know who is asking the questions. And that will then put you into the chat room and allow you to ask questions. And feel free to shoot questions anytime while the speakers are talking. It will not be disruptive. We have people that are manning the chat lines that'll be able to get those questions over to us. As with Nikki, I think we had some wonderful questions, got some great conversation going. Also, I want to remind folks again that this will be available for up to a year for folks to go back and show and review with their teams. Again, I know there's an awful lot of maternal fetal medicine, high-risk OB teams out there that are relatively new and looking for additional education opportunities, and I think Nikki's lecture was excellent. And I think you'll find the same thing for folks that are preparing for the CAMES process as we begin to listen to our next speaker. So Janet Heschel is an Associate Executive Director for CAMES based in Kalamazoo, Michigan. Ms. Heschel has over 30 years of experience as a flight nurse and clinical director, in addition to educator on a regional and national level. She has also served on the CAMES Board of Directors representing the American Association of Critical Care Nurses and a site surveyor since 2005. So she's well versed in CAMES. She is active in publishing both research and texts pertinent to the specialty of transport medicine. Contributing writings include Patient Transport, Principles in Practice, 5th edition, The Walls, Manual of Emergency Airway Management, 4th and 5th edition, and Transport Nurse Advanced Trauma Course Provider Manual, 4th, 5th, and 6th editions. Currently, the ASTNA Transport Professional Advanced Trauma Course. Jan, I met through a mutual friend, Tammy Rush, a few years back, and I fell in love with Jan. She's such an energetic and outgoing individual. She's got a wonderful knowledge base, especially when it comes to CAIMS. A lot of teams are afraid of CAIMS. They feel like they don't want to go through the CAIMS process. It's going to be too overwhelming for them. When you listen to people like Jan and Dick Orr talk about CAIMS, you begin to understand that what it does is it actually is there to help you to become a better team. And if all you did was go through the CAIMS process and go through the standards, whether or not you went for certification or not, I guarantee you're going to be a much stronger and a much safer team than if you never even did anything whatsoever with CAIMS. CAIMS has turned into an invaluable asset, and I suspect in the near future is going to be setting the standards for which all transport teams have to follow. Without further ado, let's listen to Jan Eichel.
Hi, my name is Jan Eichel. I'm here to talk to you today about CAIMS, the accreditation and benchmarking process. CAIMS is the Commission on Accreditation of Medical Transport Systems. So let me tell you a lot about that. But first, I'm going to tell you a little bit about myself. You can go ahead and scan that if you'd like my contact information. You might need it to talk about CAIMS in the future if you're considering applying. So my background is I have been a transport nurse for over 30 years. I started out in OB, I worked in the ICU, I worked in the ER. I did a lot of adult transports by ground. And then I got into the rotor wing and fixed wing business, where in Southwest Michigan, we transported patients. Usually a half an hour to an hour was a long transport. And again, I transported any age up to, neonate to adult. The process of this over these many, many years has been that many things have changed. We've become much more safe. And that led me to working for CAIMS, where I've been for 5 years as the Associate Executive Director with a focus on clinical. So that's a little bit about me and my background. I do want to tell you that I do not have any financial relationships and will not be discussing any investigative or commercial products. So what is the Commission on Accreditation of Medical Transport Systems? CAIMS is one of the grassroots projects that developed in 1988 after an alarming number of helicopter EMS accidents occurred. There were no standards at that time. He did a feasibility study to address the safety in patient transport. There was a time in transport where we just took a handful of equipment that we thought could be useful and put the patient in the back of an ambulance and went down the road. There was no consideration to what might be needed for training, securing devices, making sure that we would have enough oxygen. It was pretty loose, and as a result, it was pretty unsafe. So CAIMS incorporated in 1990, and they published their first standards in 1991. So we have now just published our 12th edition standards. So we usually do a new edition with updates every 2 to 3 years. The CAIMS mission statement is that it is a peer review organization to improve patient care and safety in the out-of-hospital environment. You can see the vision statement and the CAIMS values. What we strive is for the industry itself, you as care providers, to give us the standards that you feel should be improved upon. When we look back at photos of transport, you can see that in the past, rotor wing transport especially had been unregulated. The picture of the neonatal nurse wearing pretty much what she would wear into the office rather than anything that would be geared towards safety and clogs. And the isolette itself had very limited access. It was not built to be put into an aircraft, and they were wearing headsets instead of helmets in a very close head strike area. The cartoon picture there is just a rendition of helicopter flying where you might notice that he is in the clouds, which now we look at weather and transport safety very closely. And in fact, we have driven regulators like the FAA and ambulance configurations to become safer for you. So regardless of whether you are CAIMS accredited or not, the industry has become safer for you because of CAIMS. CAIMS itself is a board of directors that are volunteers from various organizations. There are 24 organizations to be exact, 7 physician organizations, 2 are aviation physicians. There are 6 nursing organizations, paramedic organizations, respiratory care. So the American Academy of Pediatrics, the American Association of Critical Care Nurses, emergency physicians, surgeons, critical care transport, and of course, the National Association of Neonatal Nurses. So those are all the board members that make up the discussions about the standards as well as the accreditation decisions. The CAIMS process itself is ANSI accredited. That means that we have been approved to set the standards for transport. So much like other organizations, it is a private nonprofit, and this means that participation is open to everyone and that we look for a balance of interests. It's not run primarily by physicians or by aviation or by nursing, but there is a balance amongst all to give input and then write the standards. We do welcome input on our standards committee, and it's a wide variation of volunteers that work on that. If you'd like to listen in, we can certainly let you anytime. They are Zoom meetings. And then the standards are written by this committee of volunteers. Worldwide, we have 161 CAIMS accredited programs. That includes all modes and all ages. So this would be rotor wing, fixed wing, as well as ground or surface. And as far as the age groups, I thought you would be interested to know that we have accredited 136 PICU teams by rotor wing and 49 NICU teams by rotor wing. Now, that does not mean that they do PICU or NICU exclusively, but that means that there are teams out there on the rotor or helicopters that are doing PICU and NICU specialty transports. So it may be an adult team that does both. And there are also 80 PICU teams on fixed wing, which are planes or jets, and 58 NICU, and in ground 46 and 59 respectively. Interestingly enough, we do accredit transport teams from all over the world. We have medical wings in Bangkok, Embrace in the UK, Swissair in Zurich, and the transport team at the Great Ormond Street Hospital. When I was there, one of the policies that was very intriguing to me was their process and their policies and protocols for transporting conjoined twins, which was very interesting because they bring them in from around the surrounding countries to take care of and treat. So as we talk about CAIMS and what they do, let's talk about what you do. So how many here are looking at improving patient care and transport safety? Everyone who does transport safety looks at that and wants to do the best job they can. Everyone wants to go home at the end of the day, and everyone wants to have a very safe transport team. But how many of you equally dedicate your time in improving patient care and safety? We tend to lean towards, as caregivers, improving patient care always, but how often are we really looking at transport safety? So that's where CAIMS has that balance, that synergy, giving you the same goals for the different roles that are providing transport. CAIMS knows that excellence is in the details. If you are looking at becoming a level 1 trauma center or maintaining that certification, or a level 4 NICU, or maybe you're looking at the Malcolm Baldrige National Quality Awards, or you're getting your MSN or MBA. Much like CAMES, these look like big, daunting accomplishments, but one bite at a time, one piece at a time is how this is accomplished. And the devil is in the details. Attention to details is where quality matters. So what about the CAMES process? Well, the focus is on patient care, and we all tend to have a very good focus on that. But what about safety and then education and competencies? That's what the focus of these processes are. These processes could be internal, such as how do you accept a patient? How do you transfer care? How are your protocols developed? Those sort of processes are looked at closely within the CAMES standards. Some external processes would be loading and unloading the patient. What's the safest way to do that? How do you do that without having any back injuries or finger pinches? Then do you have policies on lights and sirens? When is it the safest to use or not use lights and sirens? Or do you just go with what the driver up front decides? It also looks at your vehicle maintenance. How are your helicopters, fixed wing, or ground surface vehicles maintained, and is it to the highest standard? Then it looks also at fatigue. Are your drivers and pilots getting enough rest? And what is enough rest? We know that the FAA has specifics, but outside of the FAA, there are very little standards for that, except CAMES. So what we look at is that there are many moving parts to do a transport. It's not just the patient care. So all of these moving parts need to move together. They need to move in a synergistic manner. You need to have one goal, one playbook, one way that everyone is in agreement as to how to do a transport. The reward itself is in the process. Developing the processes within your team and the best practices stimulates a great amount of discussion on safety and the transport process. You might find best practices would include training such as HPS or human patient simulation scenarios. You may find that you discover best practices on fatigue or weather risk assessments. Maintaining a safe transport with temperature mitigation with your patient and with your equipment and your drug storage. So these are the things that in discussion, you will decide what is best for your program to meet the standards. So the standards address many things, such as clinical experiences for low volume, high risk encounters. With me, that included neonatal. I took the time because of my experience to make sure that I was able to care for neonatal and pediatric patients because I didn't get very many in my call volume, my day-to-day flying. That experience that I got at the bedside from the experts in the clinical units was invaluable when I had to go take care of patients. And they were something that I didn't see very often. There's a repetitive training in clinical and safety. One of the things that not just airway management, which is a great clinical training standard, but also for safety. How do you egress the vehicle that you're riding in? If you had a cabin fire and you had to get out quickly with the patient, how would you do it? And if you practice that repetitively, you get that psychomotor skill where it automatically occurs almost without thinking in an emergency. It definitely promotes effective communication with local as well as regional training so that everyone understands your capabilities and what you'll be able to do. It also decreases wasted time that way. We're looking at evidence-based protocols. We look at a sampling of protocols, and I'll talk a little more about that at the end, but that sampling of protocols is going to give us an idea at CAMES if you're using the latest standards and the latest evidence that's been published. Evacuation and survival. Again, do you know how to evacuate the vehicle that you're transporting in, as well as taking the patient with you? And if you do evacuate, are you schooled in survival training as to, we can all go ahead and call on the phone and hope that somebody comes and gets us right away. But there are times when cell service is very bad. There are times when your cell is lost. So understanding what you need to do for that is one of the CAIM standards. There's also fatigue and stress management that includes a risk management, so that everyone on the team, whether it be the communications or your driver or pilot, as well as your team, understands how to recognize fatigue and stress, because we know that studies have shown that the decisions we make under stress might not be the best decisions. Another thing that the standards address that you might not have a policy for that you would need is, what are your responsibilities if you come upon the scene of an accident by ground? We have responsibilities, and rather than, is there a patient on board? Who do you take care of? There's got to be a policy in place for those kind of things. So I wanted to give you a case review on my experience, because I think that sometimes showing how the standards work is easier than telling you how they work. So I'm going to give you a story with a happy ending. So this case review is A.L. He is Amr is his name, and he was an 11-week-old male at 5 kilograms. He was age adjusted to 7 weeks. He was a NICU grad. And as I said before, I had limited experience with NICU and pediatric, although our volume was probably 25% pediatric. So we were called at 1442 for a rotor transport by helicopter from a neighboring hospital. And that was at 1442. A.L. had uncontrolled seizures when he entered the emergency room. He also had a rightward gaze, and his mother had stated that she was giving him a bath and he slipped under the water. She may have panicked. She rushed him to the nearby emergency room, which was a very small emergency room, and they did not have an OB unit there, so they had very little neonatal equipment. So very little was there for them to work with. Since they thought that his rightward gaze was a sign of uncontrolled seizures, they went ahead and ventilated him with a BVM, gave him Ativan, went ahead and intubated him. And sometime during the intubation process, we're not sure what happened. It was a little bit of a gray bit of information at that point. He needed CPR. He became pulseless. And they went ahead and started compressions, and they said compressions were for less than 1 minute. And then they were able to get pulses back. During the time that they were doing compressions, he was extubated accidentally. In the documentation, that when they had intubated him and started, his ET tube was being secured at 17 centimeters, which again, he was 5 kilograms. So we thought that that might have been the initial problem altogether. During the CPR, when he was extubated, that probably accidentally completely improved his care. So we arrived at the bedside at 15:12, and using the PALS triad, we looked at his muscle tone, and it was good, but he was totally unresponsive. His color was very pale, and on the Braslo tape, he measured in the gray zone. So we thought, well, he has uncontrolled seizures, reportedly. So was he a shaken baby? Was this child abuse? Did he have an intracranial bleed? We didn't know at that time. So we needed to get him back to the PICU where they had accepted him for patient care. In most transports, we would take a PICU or a NICU nurse with us. But at this particular call, the pediatric intensivist had decided not to wait because the child was in arrest when they called. And he said, go ahead and just launch the regular rotor team and get there as fast as you can, because they need help in this small ER. So our initial assessment was that he had a 4.0 uncuffed tube. And at this point, it was at 14 centimeters. He had equal chest rise, bilateral breath sounds. He had no gastric sounds. And they were ventilating him through the tube at greater than 30 per minute. His circulatory status was a cap refill of less than 2 seconds. He did have strong peripheral pulses, so we were happy about that since they had reported that he had been pulseless when they first launched us. His heart rate was 190 at this time, and he had a blood pressure of 108/56. Now, at this time, he was already on a neuromuscular blocker, and his pupils were non-reactive. He had sedation, but he still had a heart rate of 190, so we weren't really sure, was he inadequately sedated with that neuromuscular blocker? Was he seizing, or was he bleeding? His temperature was normal. He had no rashes, and his glucose was also 174. We adjusted his ET tube immediately upon arrival. He had bilateral breath sounds now, and it was adjusted to 12 centimeters. And we also asked them to reduce the ventilation rate. With a change in the ventilation rate, we also put on a bag with a gauge on it. We wanted a manometer on it so that we could tell that how much pressure that they were using with their ventilations. We also put PEEP on at 5 centimeters. We advised the respiratory therapist to do an inspiratory hold because she was ventilating so quickly. We really didn't feel that she was adequately opening the alveoli. So we sort of gave her some hands-on and went back to putting some of our IV meds on the pump and also giving him another dose of Versed. We went ahead and called back to the PICU to talk to Dr. Beck, and he ordered a loading dose of Dilantin. And we got a little bit of secondary assessment from this patient. She was a vag delivery with no complications except for being premature. And the parents were there in the emergency room, and they did seem appropriately concerned. The mother was a little bit panicked yet and a bit remorseful that she had let him slip under the water, although she said he just slipped quickly, came right back up. So we weren't sure we were getting the whole story, but we were just going to carry on. His chest x-ray that was done prior to our arrival, prior to our adjustments, was that he had a right main stem intubation. And we had already assessed that and reassessed and repositioned it at 12 centimeters. This is just a picture of the kind of manometer that we use on our bag, and that it would be that so that we can control the amount of pressure. The respiratory therapist was able to slow down and make sure that she did not ventilate the patient in the red zone before we were able to put him on our ventilator. We moved him to our stretcher, wrapped him in warm blankets, had him in a restraining device. During the time of movement, he could drop his sats into the 80s and rise his end-tidal CO2 very quickly. When we first arrived, his end-tidal was 29, and we were trying to get it into a more therapeutic range. But when they would ventilate too quickly, she would get it to drop. And instead of ventilating quickly, we were trying to slow down, do an inspiratory hold, and also put a little tension on the ET tube. That seemed to help quite a bit. After we loaded AL into the helicopter, we were en route to our tertiary care hospital with a PICU. He had hearing protection on, and we put a Ballard suction in place. We did have to suction a few times to make sure that that tube stayed clear. With a tube of that size, it's probably large for you, but it was very small for us, and it tends to clog easily. We did ready chest needle decompressions kits because we were afraid that he was developing pneumothoraces that would be developing into tension pneumos because his chest x-ray prior to us leaving had shown a right mainstem intubation, and we were afraid that he had at some point had a pneumothorax or pneumothoraces, although it didn't look like it on that x-ray that they showed us. We went ahead and repeated his glucose check, and it was okay. The Dilantin infusion was complete. His blood pressure, heart rate, and ventilatory rate were doing fine. His end-tidal was 35, and his sats were 99. We had him on our LTV 1200 at that time with a PEDS circuit. At one time, his sats dropped to 91%, but with suctioning and an inspiratory hold, we were able to go ahead and keep his sats high. We arrived at the PICU at 16:30. It was a very smooth transport, a very smooth unload. He was taken to the PICU, which is a bit across the campus from the helipad. But I want you to note the time on that. At 16:30, he was in the PICU almost 2 hours exactly from the time that he had slipped under the water. So he was in the care of a pediatric intensivist very quickly due to the systems that were put in place. His vital signs, as you can see, when we arrived at the PICU, were all pretty good. His lung sounds were not changed, and he didn't have any seizure activity. His neuromuscular blocker had been greater than 1 hour since they had given that for intubation and ventilation. And so we were fairly confident that what we were seeing now was a true picture of his status. He was then taken immediately to CT. We checked up on him about 2 hours later at 6:30 in the evening, and he had bilateral chest tubes in place. His head CT was negative, but he did have bilateral pneumothorax. And here's his chest x-ray, and you can see that the pneumothoraces were fairly large, easy to see. They were bilateral tension pneumos. So we were very lucky that we didn't have to needle his chest and that we were able to give him controlled ventilations. I see he's got a NG tube in place, but he sure does have a big stomach bubble there. So this is AL. This was his day 3, and he is ready to go home. He did not have any further seizures. There was no cause for the seizures found. He may have been a little hypoxic from slipping under the water. Parents were very concerned and caring and took good care of him. There was never any fault found there, but there were never any seizures caused either. So it may have been iatrogenic from having had a right mainstem intubation and also having hyperventilating him too fast. And all in all, he was a sweet little boy who, with really good care and really good outreach, was able to do well. So when you look back at this, what was the CAMES difference? Well, some of it was dispatch and response training. We were at the bedside within 30 minutes of getting that call, and then we arrived back at the PICU within an hour and 20 minutes of him slipping under the water and arriving before he even arrived at the ER. So when you look at how your team is operating, sometimes some of the most important things are before you even arrive. I think we all look at the clinical training. We train on low volume, high risk items. We're ready to accomplish everything we need to with patient care. But what about the system-wide process? Are the referrals going very smoothly? Are you looking at making sure that communication is seamless for the people who call you and that they know what you can transport versus what you cannot? There are always transport safety considerations such as weather, size, age. Do you do ECMO? Do you do other things that they may or may not, you may need to refer? And does your transport center know how to do that quickly so that the patients get care as soon as possible? And then there's follow-up and feedback. In this case, we still had to make follow-up for better care in the future for that hospital. We had to talk to them about some of the things that we could do better, some opportunities for improvement. We wanted to make sure that because they had a very high anxiety about this patient, that the next time a small patient came in, that they were able to take care of them. And we did some follow-up and some education, and we hope that they're better prepared. So now that you know what CAMES does to be different, I want to challenge you. So start with the standards. The standards are online at cames.org. And when you look at those standards, you're going to be looking at them one at a time and asking yourself 2 questions. Do you meet this standard, and how do you prove it? So do you do this training, and then do you have records of that training? So these are the criteria that are used to evaluate your program. So these are available as a download for free at CAIMS.org. The CAIMS standard, again, are written and accepted by members of the transport industry. So the people who sit on the board are the ones that approve and ratify the CAIMS standards, but the standards are written by the nurses, physicians, pilots, and EMS companies around the nation and around the world for the global standards. And of course, this includes the AAP and NAN. The sections of the standards are broken down because, yes, they don't all apply to you, but many of them will. So the first section is management and staffing. So it's based on your scope of service as you have defined it. Do you do ECMO? Do you do only certain ages? So do you do all modes of transport, or do you do only certain modes of transport? The second is quality and safety. So you're looking at quality benchmarking and utilization review management. You're going to make sure that you're being utilized for appropriate modes of transport as well as appropriate teams. And that way, the right team is going. If there is some inappropriateness or some fallout, well, then we can follow up with that. The next section is patient care, and that's the patient care area is one that we focus on naturally as healthcare providers, and that looks at training and competencies and transport-specific certifications and just culture. The quality and safety looks at not only benchmarking, but safety training and policies internally and externally versus just looking at patient care. It looks at the safety of the vehicle as well. The communications section looks at staffing and training, and are they able to keep communicating with you in an emergency if they should have to evacuate? Will they still be, do they have a method in place where they still will be able to take calls, transfer calls, and help you when you're out on a transport? The next three sections are the modes of transport, and those are optional sections based on if those are part of your scope of care. Do you do rotor wing? Do you do fixed wing? Do you do surface? You may do one or all three, and those are the three sections that you would fill out for the standards and need to be compliant with. They are virtually the same or similar in that they all look at fatigue, they all look at vehicle maintenance, they all look at maintenance of the helipads or the securing devices in the vehicles. And so when you look at those would be individually based on your scope. So you may not need to do all of them. After you've looked at the standards and you've decided that you'd like to go ahead with the process, then you would need to complete the initial application. That initial application is online. It's not very long. It's only one page. The fee is $1,000 to get the process started. And that gets you a large packet of information, including a hard copy of the standard and digital copies of our policy manuals for you. And then your PIF is emailed to you. And as you might be thinking, what is a PIF? Well, the PIF is a program information folder, and that's composed of multiple parts that are communicated with you and involve a lot of uploading of documents. And this is completed prior to us performing a site visit to look at your program in person. The process is that you would receive the online PIF, and you can take up to a year to complete that. And you might be thinking that that's a very long time. But again, the PIF itself is large. With all of the sections that we had talked about, there are over 100 attachments for every program. Some of the attachments will be under management and staffing, such as scheduling and how you do background checks. In quality and safety, we would have you upload spreadsheets of what you're monitoring, tracking, and trending with loop closure. With safety, we would be looking at the training that you're doing with outsiders as well as internally. And then with patient care, we would be looking at how you're completing your training, whether you're including all of the ages and types of equipment that you carry. Under communications, we would be looking at also the type of training that they're doing. After you have looked at and filled out your PIF, you would return it to us and we would schedule a site visit. The site visit is usually 1 to 2 days, depending on how many bases or how many teams that you have that we need to look at. And then those teams that we look at, we would complete a report that would go to our board. When that board looks at your report, it would be blinded with a 6-digit number. The board looks at each program, not knowing who they are, and also not knowing exactly the names or locations of the people involved. This makes it to be a fair and unbiased review. The board meets 4 times a year, and so after your attachments have been reviewed and your report has been reviewed, then you could receive full or probational or conditional accreditation, and you would be able to advertise as such. We look for substantial compliance. There is no program that 100% is able to look at all of these standards and be 100% compliant with all of them. So what we're looking at is maybe you have achieved compliance in 75 or 80%, and you'll get a letter stating that we would like to see your progress on some of the things that we see an opportunity for improvement on. Here are some of the comments of some of the programs that have gone through CAIMS accreditation recently. The quality improvement process improved and become more inclusive with all entities of the program. QM tends to focus clinically on the patient care metrics, but it needs to also be part of communication, safety, aviation, EMS, every aspect of your program. Every one of those turning gears has to be part of your quality improvement. So their link now with safety, education, and quality has improved our processes and information sharing and loop closure. The next comment, CAIMS provides us with standards that make us safer and higher quality. And our program is deeply committed to proactively adopting patient-centered, evidence-based best practice. It demonstrates a commitment to safety, leadership, quality, education, and innovation. It also demonstrates to your hospital and your partners that you meet and exceed industry standards. Another comment, I've worked inside CAIMS accredited services for years, and this was my first opportunity as an administrative role to be part of the accreditation process. The standards caused many thoughtful discussions, and I can certainly see areas of opportunity for improvement due to the process. And that's what I was trying to say earlier, is that these will bring facilitate those discussions so that you can come to consensus and decide what's best for your program. Living the standards elevates the program, and in my opinion, one can tell the difference between programs not accredited, and we practice living the CAIMS standards, and we are a better program for it. The value of CAIMS is in the process. It is a team approach, and when your team works out the solution that they feel are best, it increases the buy-in and also the compliance. It becomes a huge sense of pride as they see successes and improvement. So the result is that you get this balance and synergy. It is not just that patient care, although it is in the forefront and it is one of the pillars, it is that safety and quality also matter. So safety and patient care become a balance. Then it is a team building experience and a goal, and when it's achieved, there's a certain pride in that. You become more proactive in looking at what might occur and having policies in place and training so that you're not reactive when something happens. It also helps you with benchmarking and always improving your program and improving your processes. And in looking at benchmarking, the GAMUT metrics, I'm sure many of you have heard of this by now, that GAMUT is the data analytics platform for medical transport programs, where you track, report, and evaluate your performance. And those are on transport-specific quality metrics. We can't take everything we do inside the hospital and hope that it applies to the transport. You need to be transport-specific to evaluate your processes. And this is a worldwide community of professionals dedicated to safe transport of patients. There are some value-added things that we also give you besides evaluating your accreditation process in the CAMES programs. One of them is the critical elements. I use the example of the PED sepsis protocol. We look at 5 at this time protocols that we pick out of your protocol manual, and we look at critical elements of those to see if you are looking at the most recent evidence-based patient care values. So these are weighted, and then you are given a score back on those critical elements on those protocols. We did a small study. We hope to publish that after next year, but we had 34 programs that we looked at in 2019. They had an average score on pediatric sepsis of 32.5. And then we asked them to please do revisions. And when they resubmitted them in 2022, because they were fully accredited, they resubmitted everything 3 years later. So those same 34 programs with their pediatric sepsis in 2022 raised their scores to an average of 60.5. So that was a 47% increase, which represents a great deal of improved care for many, many patients. When you think of that the average was 32 before and they raised it to 60, and over that 3-year process, how many patients got better sepsis care because we were able to give them that feedback? This is just the scorecard that shows in 2022 in the blue how much they raised their score on pediatric sepsis. And in 2019, the orange was what the score was in that year. This is the sepsis scorecard that the program would get, and it would show you that correcting hypoglycemia and hypocalcemia were part of the critical elements. Giving antibiotics are part of the critical elements. Monitoring lactates, and if shock is refractory, transporting to an ECMO center. So those were the kind of things that we were looking at in the critical elements for pediatric sepsis. And the programs would receive this scorecard to see where they could make some improvements and add to their protocol. Another added value, last but not least, is the safety culture survey. Again, we consider safety to be of the utmost important. And so we want you to do risk assessments for patient care as well as your transport vehicle. So the safety culture survey is sent out to all of your staff, and that is the safety attitude questionnaire. That is a benchmarking questionnaire from the University of Texas Medical School in Houston. So it is a validated, vetted test. This anonymous survey goes to all associates, and then it comes back to us, and we score the program, your team, on these 6 areas, and then we benchmark you against other CAMES accredited programs. The cultures that are scored are teamwork, safety, job satisfaction, and working conditions, and stress recognition. And this is what the scorecard looks at like. So we look at and get comments back. Do you have green on green? Is there rest for your drivers? Do your staff get enough rest? Are you mitigating risk? Does your staff recognize stress and how it affects their patient care? So some next steps that you might wish to take, I'm going to wrap it up now, is consider the benefits of accreditation to your organization. Review the 12th edition standards and see if they're comparable to your current practice, or if there's any way that you would like to go ahead and benchmark your practice and discuss, is there ways that you could implement some or all of these standards? When you look at the standards, remember, you need to know where you're at so that you can grow. You have to assess. And sometimes an outside assessment is the best way. CAMES also offers a consultation service. If you decide not to be accredited, we can just do a consultation with your program, with your policies, with your procedures. We can do an on-site visit, or we can just do a paper consult, and that's always available, even if you decide not to become accredited. Remember, if you want to get the best possible outcomes for your patients, you have to have the best possible processes. So for more information, if you would like to use my references, you can go to CAMES.org and get the 12th edition. You can also find the CAMES best practice, and the CAMES best practice is hundreds of examples of how other programs have met the standards, and they have been willing to share those with you so that you can look at how they do risk mitigation, how they do training, and some of the other things that, maybe helping you get started. So I'm going to go ahead and wrap this up and stop the video. And what we'll do is have time now for questions. This is my contact information. If you want to take a screenshot or you want to shoot it with your phone, you'll be able to save me in your contacts. Now I'm going to go ahead and stop. Thank you so much for your time. We'll be logging in now live.
Hey, Jan, can you hear me?
I can. Can you hear me?
I can. All right. I guess my screen doesn't have you on it, so I wanted to make sure you were on. All righty.
Yes.
Well, thank you so much. That was an awesome presentation.
Thanks, Rob.
I didn't realize the origins of CAMES. Back in 1998, in the summer of '88, I did my very first transport. It was from Washington, D.C. to Frankfurt, Germany. So you kind of might say it hooked me.
Oh, yeah. That's amazing.
Yeah. And then in the military, Bill Bennett and I got together with General P.K. Carlton, and we started the CCAT teams. And that's when we started the origins of our operating procedures, a lot which align nowadays with CAMES.
Yes, very much so. And it's interesting because in our special operations and other accreditation entities that we do, to get military contracts, many of them have to have CAMES accreditation.
Very much so. That's how much strongly we believe in it. I mean, I think CAMES is going to take hold with the transport community as much or even more than JCHO has within the hospital as a whole. Well, we got a lot of people with some great questions here, so let me jump off here. So, very beginning, for those considering CAMES certification, do you have a recommended starting point?
Well, in the accreditation process, the very first thing you should do is look at the standards. Just download them from the website and look at them, because you're going to find that you already do many of them. But you're going to want to look at those that say that you need a policy in place where maybe what you have is tribal knowledge and you're sort of doing it. But if you don't have that policy, you can't be really held accountable. So you want to get writing some policies, and we all know that takes time. So even if you're just looking at the standards and you want to give yourself more than that 1 year from the application process, go ahead and start now writing some applicable policies that you can put into place. It'll only get you ahead. I would say there are, I would love to say there's no bad time, but that's just not true. It takes some staffing time to do this. And it also, if you're going through a really big transition, like somebody is leaving that's been in a really big leadership position, it probably isn't the best time to start throwing a lot of change in. But I will say that when I first did CAMES, I was part of a merger with two competing helicopters. And so since we were coming together and we had all applied for a job there, we decided that we would not take X and Y's policies, that we would look at the CAMES standards and we would write all our policies based on that. So what could have probably been a pretty tough time turned out to be a really good decision to be one of the first programs to be accredited by CAMES, because we just took the CAMES standards and decided to use that as our template to build a company.
So literally, it's a checklist. You follow the checklist,
Yes.
and you'll definitely do what's necessary.
Yes,
I guess
it
along
is.
those lines, you mentioned a major event. Say it's a new program, or say it's a program with new leadership, or say it's a program that just added rotary wing and fixed wing. What is the average time frame that you recommend for these programs to collect the data and the knowledge and learn before they should actually approach CAMES and fill out an application?
Yeah, I would say give yourself 6 months. Give yourself 6 months to collect data. One of the reasons I say 6 months and not a lot longer than that is because you need to submit a year's full of data into your PIF. And so we want you to collect the right data. You might have some things, but you might be missing how many times you use lights and sirens. Because maybe you just didn't feel you had to track that very closely. But that's a safety metric. And so I would say if you had a change, like someone new was coming on board and they were feeling like that they had built a team and were ready to step into the CAMES process, then 6 months probably would be enough time.
Okay. Is there a medical legal benefit of being CAMES certified? Well, that's a touchy question, isn't it now?
Yeah, medical legal. Boy, I'm not a lawyer. I will say that often when people talk to us, they say that their risk management systems within the hospitals and within their larger corporations, they use the CAMES standards as a benchmark. So I would say that if you were at that benchmark, then you probably would be safer than someone who is not maintaining that benchmark on a daily basis.
That makes sense. Makes definite sense. What are your best tips for a team going through accreditation for the very first time? And I think this is a really interesting question because before I introduced you, I had mentioned to folks the trepidation that teams feel and the overwhelmingness that they see when they try to read through the CAMES standards. And because of that, I fear sometimes it turns away good teams that probably would do very well in the process. Do you want to expand a little bit on that?
Yeah, I'm happy to. When you go through the CAMES accreditation and you start looking at the different sections with safety and communications, and you start having meetings and talking about this, I think it brings everybody together with really everybody wants what's safe and best for the patient. Everyone wants that. And when that is the ultimate goal, people start coming up with innovative ideas and ways to do things maybe that you didn't expect. And there could be some change in that way. And I think that when you talk about trepidation, it's like any large project. You eat an elephant one bite at a time. And when you get done, you have this I can't tell you, this huge satisfaction of a team that has done a really job well done. And it also is something that people wear with pride and promote with pride on their transport system. When you look at hospitals, a lot of them, they love the transport team, but when you are shown to be accredited at the highest standard, that's something that leadership within your hospital looks upon and recognizes immediately.
No, absolutely correct. Absolutely correct. Thinking about, again, some of the trepidation these folks go through and everything, the 12 standards, that's free online for anybody to download.
Yes, it is.
Okay.
The only thing that is not on the free download is the addendums because they're kind of numerous. Mm-hmm. But all the standards you can look at any time and download them just from the website.
So they don't have to fill out the application right off the bat to start the clock for the 1-year time frame?
No, not at all. Not at all. You can look at the standards. You can start deciding where you might meet them and where you might want to write a policy. And then you can start doing that, and you can wait a whole year or 6 months and then go ahead and fill out that application and get the PIF.
No, that's awesome. How many teams take advantage of the consultation services? I know that at one point in time when we were getting ready to go through the process, I think it was in San Francisco in 2016, I was talking to Dick, and he had mentioned this opportunity for consultation, and I could bring Dick here to Kansas City and so forth. How many teams take advantage of that?
Well, that's really interesting because not only do teams take advantage of it the first time they go through, but sometimes they do it as a reaccred as well. So probably we do maybe 10 consultations a year, and most of those decide to go through with accreditation, but some of them are already accredited, but they've gone through a big transition, some major changes, and they really want somebody to come in and look at their paperwork and make sure their policies are still meeting the standard, and then they go ahead and finish their reaccreditation because the consultation has nothing to do with the accreditation. It'll be a completely different person who is an expert in your area. So it would be a pediatric intensivist or a neonatal person if that's your scope of care. And then that is completely separate file. That has nothing to do with your accreditation visit.
So you're not, if they come in there and find a whole bunch of areas that need significant improvement, it's not going to affect you.
No, you just get a written report and it's between you and the consultant.
Oh, that's awesome.
And then it does not go into your accreditation file. You can fix all those things and then the accreditation process would start.
That's incredible. That's incredible. A lot of teams don't have or own their own assets, and so they work through vendors, whether it be at the ambulance level, the rotary wing, or the fixed wing. They are also encompassed in the CAMES site visit, correct?
Yes, that is correct. Whatever mode of transport that you use would also be part of the CAMES process, and we would ask for attachments from them as far as their licenses and their FAA documents. And as well as we would interview the drivers, the pilots, when we were on site to make sure that they understood and were part of the training on a regular basis that is required by CAMES. The hospital that owns its own ambulance would be able to control how much rest their driver gets and how the vehicle is maintained. If it was a vendor of an ambulance service that was providing an ambulance for you on a as needed basis, then you would need to talk with them and have it written into your contract that the ambulance would be maintained and that the driver's training would be upheld as well. So it's done all ways.
Good to know. Since there is no transport-specific certification for high-risk OB, what certifications do you recommend for HIROB teams?
That's interesting because I just did a talk 2 days ago, and we were talking about the high-risk OB not having. So I believe it's RNCOB. Is that correct? I was looking at my notes.
Yes.
Yeah. So, and that would be appropriate because if there is a transport-specific advanced certification, we would like to see that. But if there is not, then there is not. But if someone would like to write that, that would be great.
I know that my neonatal team had to learn some additional pediatric since the transport certification combines the two as opposed to separating them out.
Yeah.
Back with high-risk OB, how many high-risk OB teams, and I'm not sure if you know this or not because people don't realize that Jan and I were in a little email chain not too recently, but I'll let her answer it just the same. But I already know the answer having communicated with her. How many HIROB teams do you have that are accredited in rotary wing, fixed wing, and surface?
Well, I don't have that number specifically of a standalone high-risk OB. I can tell you that probably over 100 teams in the United States transport high-risk OB and have been trained to the CAMES standard to do that, but they are not standalone high-risk OB. There is a section in the CAMES standard about specialty care and giving that care, such as Doppler fetal heart tones and how often. In fact, preeclampsia is one of the protocols that we look at for critical elements because it is high risk and low volume. And we want to make sure that no matter what team is going after, that they are doing it to the standards that are the latest evidence-based care. So that's not really an answer, but.
That's okay. You know, we understand there was a neonatal-only team that was the first ever to get accredited, so maybe there'll be a maternal-only team this fall that'll get accredited.
That would be wonderful.
Possibly from the same institution.
Oh, that's awesome.
For specialty teams, what level of survival education do you recommend? Oh, this is a good question from an old military guy like myself. I like this question.
Yeah. Well, I can tell you that when you are out as a transport team, it does not matter, does it, that the age of the patient or the type of patient you're caring for. Survival is for you and the patient to do well and to not have any ill effects. So you're going to be trained as any transport nurse or medic would be trained. And that would include that you have a survival kit on your vehicle and you know what's in it and you know how to use it. Not just having it back there in the back corner and never knowing what's in there. But obviously it would be different if you were in the mountains in Utah versus you were in Kansas City. You would have different things in your survival kit. But knowing how to make sure that you can egress a vehicle that's disabled and is also maybe a threat, and knowing how to stay warm. Right now in the United States is pretty much everywhere. So, keeping yourself and your patient warm, and then knowing how to signal. How are you going to get a hold of someone to make sure that you're found? Are you being tracked continuously in the comm center by air or ground? And then they're going to be looking for you. And how are you going to signal to them? Because you need to be able to either have an audible signal or a light signal, something like that. So those are the kind of things that, yes, in survival training you need. And if you're going over large bodies of water where you might actually be ditching in your aircraft, then you're going to need to do water egress training as well. So it just really depends, and it's geographic as well as the type of training that you do, but everyone needs it.
Absolutely. And, as somebody that's gone through that type of training at School of Aerospace Medicine in San Antonio, whether it be the water egress or the campsites outside of the San Antonio area in the woods, or up in the state of Washington, which was the worst because that was the cold survival training, understand. And this is interesting, and I like this because I want to go ahead and ask because I think it's important. Does just one member of the team need education to meet the standards when it comes to survival training? And I guess let's say meet the standards in one part, and then what would you recommend as another?
Yeah. So every person who's on the vehicle needs to have survival training. Every person who's on the vehicle. And the standard now says that every person on the vehicle has to have a signaling device at a minimum on their person. Because we do know that if you rapidly egress and you're not able to get the survival kit, that you should at least be able to signal someone. And we get this information from crash survivors and what they found to be useful. So we're not looking at that you go out and be able to build a fire and cook a rabbit. We're looking at you being able to signal the help that's looking for you and make sure that you're able to survive long enough for them to get to you.
Definitely
But
sound
every
advice.
person needs it. Every person needs it. You don't know who will be the most competent survivor and who will be unconscious after any accident.
Absolutely. The least injured versus the most injured, exactly.
Yes.
How do you provide feedback to referring agencies or hospitals who could improve their process or have they made an error? I guess this question's asking, unfortunately, how do you break the bad news, I guess, so to speak, but yet turn it into something positive?
Right. And that is something that we have programs look at and do, and they do it many different ways. We don't dictate how you meet the standards, but what we do want is to see that you're making efforts. So I've had several programs that if it's a very minor issue, they missed drug dosages or there was some misunderstanding, then it's a phone call and we document that phone call. But if there's a whole case, like the one that I presented, where really there were multiple players in this, where really it kind of got off to a bad start. Then we went back and did a case review. We arranged for some credits and we did some pediatric training so that the EMS could come in and get some pediatric credits, and as well as the hospital got nursing credits, and the physician from the ER also attended. And it was treated as just, this was some of the things that could have been improved upon, and also this is the way that the case turned out. So they could see that there was a little room for improvement there, but yet they didn't have some of the tools there in the ER that they probably should have. And they went ahead and recognized that and actually did order some things in some smaller sizes, more than they had previously thought they needed.
Yeah. Well, I know in the transport community, we have an awful lot of folks that are dedicated and passionate about doing the very best care they can. And so if something does happen that puts them in jeopardy or their patient in jeopardy or causes some concerns in regards to the standard that may not have been met, they tend to take it very, very personally. And so I know that it can be a very difficult team and group to talk with. And so letting people know that we're not out here to be any kind of negativism. We're here trying to instead make you a better transport person and take care of better patients.
Yeah, for sure.
Well, here's one, getting back to your case now. So are known pneumothoraces a contraindication to flying due to changes in pressure? And why don't we do this in two-part? Why don't we say rotary, and then why don't we say fixed wing?
Okay. Well, so first I'll do with the rotor wing, and there are some relative contraindications to flying in changes in altitude. And I can tell you that that is where the transport advanced certifications come into play, is knowing the differences in being in a ground unit and an air unit, because the ground unit obviously has some of the stressors of transport, such as vibration and G-forces. But when you go in altitude, well, and I guess if you're in the mountains too, you could have some altitude changes driving, which would be substantial. But when you are flying in an unpressurized aircraft, whether it be rotor or fixed wing, then we take that into consideration. And we talk to the pilot about his altitude that he is transporting us at. And I'm not sure if I'll get too far into this, but if we were to have some bad weather and he were to fly IFR, which would be instrument flights above the clouds, he would go as high as 5,000 feet. But we knew we were not going to need to do that with this child, or quite honestly, my partner and I might have gotten into a ground ambulance because we might not have wanted to risk that pneumothorax expanding more. We had no small enough chest tubes. That was something that we looked at, and we said, we don't have anything small enough. We're going to have to needle his chest if he gets into any sort of a compromise, and then we'll have to go from there. But we didn't have to end up doing that. But the limitation would have been to the patient's tolerance, to answer that. And then if he were in a fixed wing, it would be probably only in a pressurized aircraft and not in an unpressurized fixed wing. So that would have been a much longer distance, of course. And if you were in a pressurized aircraft, then you could have the pilot adjust the atmospheric pressure to the patient's tolerance as well. So you have to, again, it's a process with a team. So they have to understand how important they are to helping you do the best for the patient as well.
Yeah, absolutely. I know the Airdyne air compressor, they recommend manufacture 8,000 feet, and yet most of the time the planes are pressures to 10,000 feet. So talking to the pilot is very important.
Yes, it absolutely is. And when you're documenting your vital signs, the atmospheric air pressure within your aircraft when you're flying pressurized is documented right alongside all your other vitals, so that they can see how the patient is being affected. And if you adjust it, if you have the pilot adjust it, did that make some improvements?
Yep. I still remember taking the old C-141s, and as soon as we got up to altitude, that bag of chips that they gave you in your box lunch was swelled up to about the size of a football. And I think it sounded like there was only 3 chips in there too.
Yeah.
As high-risk maternal transport teams become more common, do you anticipate representation from A1 and or ACOG on the CAMES board? That's a good question. I mean, one of the strengths of the question. Yeah, one of the strengths of the CAMES board is the remarkable representation from many different disciplines and many different backgrounds.
Mm-hmm. Yes, I would say absolutely. And in fact, if someone was interested and wanted to have someone on the board, contact us. The board is open, and we truly believe in representation from all. And so absolutely, we'd use your expertise.
Yeah, I can say as for a while, for a number of years, being the individual who was on the committee for the standards representing the AAP, I've enjoyed the talks I've had with so many different disciplines, as we went through different items that we had questions or concerns about. And most recently, I know that Dick and myself and a gentleman from the UK got together on a conference call to discuss the entitled CO2 and stuff. And it makes everybody so much smarter, and the expertise that you share. Again, getting back to the whole idea of networking that we all would like to have, and we can get together on these conferences.
Yes, we get together 3 times a year to discuss the policies and standards, as well as deliberate our programs.
Yep, that sounds great, and I'm looking forward to it. Anybody in the audience have any questions at all for Jan that we haven't already asked? All right.
And please let them know that anyone can email me with questions. I put my contact numbers up there. Send me an email, ask me questions. Maybe you want some advice. I'm happy to talk, always happy to chat.
Oh, I think Caitlin, my transport coordinator, took about 5 pictures of your QR code, so I think we're in good shape there, that's for sure.
Good.
It's been a
Good.
delight, Jen. Thank you so much. I look forward to seeing you in Denver and
Yes.
in April. And thank you for being a part of this conference for us.
Thank you so much for having me, and thank you so much for everyone for their time today. I appreciate it very much.
All righty. So, folks, we're going to take a break right now, and we will be reconvening at 3:35. 3:35, and that then will take us to our last speaker, Dr. Howard Stein. See you then. Oh.
Repeats and repeats in my ear. Don't you know, little fool, you never can win. Use your mentality. Wake up to reality. But each time I do, just the thought of you makes me stop before I begin. 'Cause I've got you. Yes, I've got you. I've got you under my skin.
Thank you for caring and helping us grow, sharing ideas that we needed to know.
But more important for all that you do,
Thank you for being you. Thank you for helping us stand on our own. Thank you for bringing the world to our home.
Music and stories that we never knew.
Thank you for being you. Words could never measure. A gift would be too small. But more than any treasure, we love you most of all.
thank you for giving your heart and your mind. Thank you for being a one of a kind.
You are our neighbor and friend through and through. Gracias por ser quien tú eres.
Words could never measure. A gift would be too small. But more than any treasure, we love you most of all.
Thank you for making us feel right at home.
You made us feel special.
Now see how we've grown. For all of the dreams that you helped to come true. All of the memories too. Thank you for being
cheers.
We love you.
Someone's knocking at the door. Someone's ringing the bell. Someone's knocking at the door. Someone's ringing the bell. Do me a favor, open the door. Let 'em in. Let 'em on in. Someone's knocking at the door. Someone's ringing the bell. Someone's knocking at the door. Someone's ringing the bell. Do me a favor, open the door, let 'em on in. Sister Susie, Brother John, Martin Luther, Phil and Don, Uncle Ernie, Auntie Jim, open the door, let 'em in. Yeah. Oh. Open the door, let 'em in, yeah. Someone's knocking at the door, someone's ringing a bell. Someone's knocking at the door, someone's ringing a bell. Do me a favor, open the door, let 'em on in, yeah. The touch of your lips upon my brow, your lips that are cool, cool and sweet, such tenderness lies in their soft caress. My heart forgets to beat. The touch of your hands upon my head, the love in your eyes shine. And now at last, that moment divine, the touch of your lips on mine. The touch of your hands upon my head, the shine so fine. And now at last, that moment divine, the touch of your lips on mine. It's wonderful, it's marvelous. You should care for me. It's awfully nice, it's paradise. It's what I long to see. You make my life so glamorous. You can't blame me for feeling amorous. It's wonderful, It's marvelous that you should care for me. It's wonderful, it's marvelous that you should care for me. Softly nice, it's paradise. It's what I long to see, my dear. My heart is working overtime. From now on, it's four-leaf clover time. It's wonderful, it's marvelous that you should care for me.
Hello and welcome back. This is the final installment of our pre-conference, Hot Topics in Transport Medicine, with a lecture being given by Dr. Howard Stein. A couple more housekeeping items because we will be going off the air after this lecture. Expect to get a, there's a baby born upstairs. Expect to get an evaluation for the conference after this is done, and filling that out and turning it back in is what will get you your CMEs and CEUs. Also, make sure that you have signed in online for this day so that you can get credit for this day. And the way that you would do that is you need to scan the QR code that's been showing up on the slide reels, or you can email amy.retzka@hcamidwest.com. Certainly, we can get that information to you. It'll be available tomorrow as well all day. But we've got quite a few folks that are signed in and are listening to lectures, but have not, or no, sorry, are not signed in, but are listening to lectures. I think it's 40-something people that are listening. We're happy to have you, and this is great. But if you want to get any kind of education credit, you do have to sign in. It is a separate sign-in. Oh, thank you very much. There is a separate sign-in than just going into the video portion. You need to hit this QR code, and it will take you to a place where you'll actually put your name and your email address and so forth, and that will formally sign you in, and that's what Amy will use then to say you were here and get you your appropriate education credits. If you have any questions whatsoever, take a picture of this screenshot right here because it's going to go down in just a second, and you can email Amy at that particular address. We'll leave that up for a second while I go over just a few other things. Once again, I want to special thank you to my collaborators, the folks, John Seegers and the folks at International Biomedical down in Austin. They'll be having a big transport conference coming up here the second week in May. Also want to say thank you to HealthStar One, and that's a branch of MedTrans Corporation. Those folks are the ones that fly with my teams, and they're a phenomenal group of very high professional folks that we are just ecstatic to have as part of our team. Also, sponsors for the entire conference, both today and tomorrow, Mead Johnson, Prolacta Bioscience, Abbott Nutrition, Philips, and I think that about does it. All right, we can go ahead and take that down. And we'll move up to the speaker slide. So this next talk is going to be our last talk. It is going to be given by Dr. Howard Stein, and it's Transport of the Infant with Suspected Cardiac Disease. I asked Howard to give this talk because I have used this talk in many lectures that I've given to my teams, as well as passed it on to other folks. Unlike Howard, who is both a cardiologist and a neonatologist, a lot of us just have our emphasis in neonatology. And when it comes to diagnosing congenital heart disease in our own NICU, we have several tools that we can rely on, including the cardiologist and echocardiography and so forth. But when you're out in the austere environment of transport medicine and you're limited as far as what capabilities you have, you need to know what you're doing out there to make sure that you can safely transport that patient to the appropriate facility. And sometimes that appropriate facility is not back to your own facility because they may need cardiac surgery. And if you don't do cardiac surgery, you need to take them to a center that does. So this is an excellent lecture. I'm really looking forward to hearing from it. I've known Howard for over 15 years now. I think last year was the first year that he and I did not get together. And so I'm happy to see him here on the monitor in just a few minutes after his talk. Dr. Howard Stein is a neonatologist and is director of the Neonatal Intensive Care Unit and section chief of the Division of Neonatology at ProMedica Abel Children's Hospital in Toledo, Ohio. He is a professor of pediatrics at the University of Toledo Health Science Campus. He is president of the medical staff of ProMedica Children's Hospital and chairman of ProMedica Institutional Review Board. He also completed a pediatric cardiology fellowship and worked as a pediatric cardiologist and pediatric intensivist for many years. Dr. Stein is one of the national reviewers of the STABLE program, including physical exam and cardiac modules. And for those of you that don't know, but if you ever get the opportunity to, he is actually one of the lead instructors for doing the cardiac module of STABLE and does a phenomenal job with that. Dr. Stein has worked with NAVA ventilation since 2008 and has taken care of hundreds of neonates on NAVA and NIV-NAVA. He is an expert on NAVA ventilation and is actively doing clinical trials utilizing NAVA in the NICU. He has published articles and presented his findings about NAVA at national and international meetings. He, along with Kim Firestone, BSRRT, who is a phenomenal respiratory therapist, by the way, developed the clinical guidelines and management strategies for NAVA ventilation in neonates. So, folks, I hope you enjoy this. Dr. Howard Stein.
Good afternoon. I'm Dr. Howard Stein. I'm the Director of Neonatology at Ebi Children's Hospital and a Professor of Pediatrics at Toledo College of Medicine and Life Sciences in Toledo, Ohio. Before I start, I'd really like to thank my good friend, Dr. Rob Holcomb, for inviting me to speak at this conference today. I've known Rob for over 15 years, and I've always been amazed and impressed with his undying enthusiasm and endless energy as he works on a local and now as well as on the national level, educating people in the skills that they need to do safe and successful transports, as we not only bringing our babies to the NICU, but we actually taking our NICU to the babies to provide them with the optimal type of resources that they need to come back to our hospitals in the safest way. So with that in mind, I'm really grateful to be part of this conference. And today I'm going to speak about transporting the baby with suspected cardiac disease. The disclosures I have is I'm on the Speakers Bureau for Getinge and Chiesi, although I won't be speaking about either of those products today. My objectives are that I'm going to speak about the differential diagnosis of cyanosis in the neonate. We'll discuss maternal risk factors that you should be talking about when you arrive at the hospital that should clue you in for neonatal congenital heart disease. The signs and symptoms when you examine the baby that will suggest congenital heart disease. And then we'll discuss a systematic approach to stabilizing and transporting the baby that you suspect has congenital heart disease. So we'll start with a case presentation. A term male infant is born to a 20-year-old prima gravida mom. Pregnancy, labor, and delivery are unremarkable. After birth, the infant was noted to be tachypnic, mildly so, respiratory rate about 70, and mildly cyanotic, SATs are about 78% in Romania. The referring hospital is concerned, they call for advice, and they ask for a transport team. On arrival of the team, the baby is now more tachypnic with a respiratory rate of 90 breaths per minute, and he's breathing shallow. He's mottled, poorly perfused, and his oxygen sat is only 55%, but now he's on 100% hood. His temperature is 99, his heart rate's 180 beats, and he's lethargic. The local nurses cheer when you walk in, and they run away from the bedside, and now it's all yours. So where do we start? Well, initial assessment, you go to the baby's bedside, and it's always the same: airway, breathing, circulation. And while you're assessing the baby, you'll be asking a problem-directed history. So the differential diagnosis, keeping these things in mind. Cyanosis in a baby can be caused by respiratory reasons, which is lack of oxygen delivery to the blood. So either upper airway obstruction, infection, lower airway obstruction, or something like a pneumothorax, where we're just unable to get oxygen from the outside into the blood itself. Secondly, there can be hematologic problems, decreased oxygen carrying capacity. Either there was bleeding, in utero bleeding, or postnatally. The bleeding can occur into the placenta or into the baby itself, or into the mom. Or the baby could have abnormal hemoglobin, and therefore the hemoglobin's not able to bind oxygen as well as it should. Or it can have cardiac diseases. There could either be structural heart disease, meaning that there's some mixing where unoxygenated blood is going back to the body without going to the lungs, or oxygenated blood goes out to the body, but we can't get enough of it going out to the body because there's some sort of plumbing issue like a hyperplastic left heart. Or the other problem can be poor cardiac function, where the plumbing is all good, but the function of the heart is poor, so that even though oxygen is in the blood, you can't move it around sufficiently enough to get it to the tissues. While you're looking at the baby, you'll be talking to the nurses and to the physician, the referring physician, about what sort of maternal risk factors exist in the mom. So the risk factors that we're going to ask about will be what will clue us in that this is a respiratory problem in the baby, an infectious problem, or a hematologic problem in the baby. And then we'll spend quite a bit of time talking about things you'd want to know to make you think this is most likely a cardiac issue. So maternal risk factors for respiratory problems. Did mom have an infection? Was there meconium-stained fluid? Was there bloody amniotic fluid? Was there maternal diabetes, putting the baby at risk for RDS, even in a 36 or 37-week baby? What maternal risk for infection? Was there recurrent or concurrent, a recent or current maternal infection, such as what's her GBS status? Has she had a recent UTI? Has she had some sort of viral syndrome in the last few weeks? Does she have evidence of chorioamnionitis? Is her temperature elevated? Does she have a high white count? How long have her membranes been ruptured? And what sort of risk factors are there for hematologic problems in the newborn? And this is basically based on history. Is there a family history of bleeding disorders? And is there a family history of hemoglobinopathies? If all those don't show you where to move with the baby, then comes the questions about the maternal risk factors for cardiac problems. And there's a number of different things you're going to ask about. The risk of congenital infection, a family history of heart disease, maternal diabetes, and prenatal exposure to alcohol, drugs, or medications. So first, what sort of infections can put the baby at risk for heart disease? Maternal rubella infection is probably one that we have the most experience with. And if the mom gets infected in the first half of the pregnancy, there's a 50% chance of infecting the fetus, and that can cause septal defects and myocardial disease. Keep in mind that the first trimester is the trimester of embryogenesis or development of the organs. The second trimester, the heart completes its development. And then the third trimester is the trimester of growth or storage. So it depends in which trimester puts you at risk for what kind of heart disease. So maternal rubella infection in the first half of the pregnancy puts you at risk for structural heart disease, but in the second half of the pregnancy will put you at risk for myocardial disease from a viral myocarditis. Any congenital viral infection, especially in the second and third trimester, puts you at risk for the viral myocarditis. So it's not just rubella, but it's all the torch infections, as well as the other common viral infections that we see. If there's a family history of congenital heart disease and mom has the congenital heart disease, that increases the risk from about 6 to 15-fold that the baby will have congenital heart disease, and most typically in aortic stenosis and AV canal. Now, as I go through this talk, I will have the different types of heart disease on there, but I really don't want you to focus on, could it be aortic stenosis or pulmonary stenosis or ASD, VSD? Those things are not as crucial as you just remembering these things cause a risk of heart disease. Because when we get towards the end of the talk and we talk about a standardized approach to how to treat the baby, the type of heart disease doesn't matter as much as suspecting that there actually is heart disease. If dad has congenital heart disease, this only increases the risk 1 to 3-fold. However, if you have a child with previous congenital heart disease, this increases the risk 2 to 3-fold and much higher than that with certain types. Endocardial fibroelastosis, or EF, and again, you don't need to remember that. If that is something in the history and you ask the question, the parents will come up with that diagnosis. VSDs and ASDs, those all have the highest risk. And then, of course, family histories of genetic syndromes that are all associated with congenital heart disease, such as trisomy 21. About 50 to 60% of babies will have some sort of cardiac disease. Trisomy 18 and trisomy 13, and VSD is the most common, but complex heart disease is common in both of those as well. And about 80 to 90% of those babies will have congenital heart disease. Turner's, coarctation being the most common. And remember that Turner's syndrome, the majority of those babies don't survive all the way to term. Most of them die in utero. So the ones that survive are the best Turners, and those typically have the least severe heart disease. And then some of the deletions, the most common one that we know about is the 2q11 deletion, or DeGeorge's, and these are associated with the conotruncal anomalies. Conotruncal means the anomalies associated with the aorta and the pulmonary artery. So truncus arteriosus, tetralogy of Fallot, and transposition are good examples of those sort of anomalies. Maternal diabetes, very common that we see diabetes. We see two types of maternal diabetes. We see pre-pregnancy diabetes and gestational diabetes. In pre-pregnancy diabetes, these moms are diabetic before they get pregnant. Now, remember that the fetus's blood sugar is about 70% that of the mom's blood sugar. So if a normal blood sugar is 100 in a mom, then a fetal blood sugar should run about 70. However, in moms that are pre-pregnancy diabetic, type 1, type 2, type 1 diabetics who have been diabetic on insulin before they get pregnant, these babies can be exposed to sugars of 100, 200, 300, meaning that the fetal blood sugars can be up as high as 150 to 250 during that first trimester. And again, the first trimester is the trimester of embryogenesis, when those organs are developing. So if you get a high glucose during a critical point of cardiac development, that's when you're at risk for structural heart disease, the most common being transpositions and VSDs. In both pre-pregnancy and gestational diabetics, these babies get exposed to high glucose levels in their third trimester. By then, their organs are fully developed and are now starting to grow and get storage. So the pancreas is fully developed. So when there's high glucose levels in the fetus in the third trimester, the pancreas puts out tons of insulin. And insulin is the most important growth factor for fetuses. So when these babies have very high insulin levels, they then deposit excess amounts of glycogen specifically in the heart around the ventricular septum and the left ventricular outflow tract. So these babies develop a diabetic cardiomyopathy, and it can get severe enough that they're actually at risk for left ventricular outflow tract obstruction. So again, if you've got a history of gestational or pre-gestational diabetes in a baby, and you hear a murmur in the newborn period, think left ventricular outflow tract obstruction, especially in a baby that looks poorly perfused with poor cardiac output. Maternal risk factors with exposure to alcohol, drugs, or medications. Today, we are really using a lot of medications in pregnant moms, and they are being studied, but this data is not fantastic about the safety in all of them. And most of them we learn by problems occurring. So as you can see, with drugs such as alcohol, valproic acid, dilantin, trimethadone, Accutane, amphetamines, progesterone, estrogen, maternal PKU, all of these not uncommonly used in patients, and in particular in pregnant moms. They are all associated with a high risk of structural heart disease. Again, if these drugs start being used in the second to third trimester, the risk of structural heart disease is much lower because the heart's already formed. But then you run into the problems of functional heart disease, especially with certain drugs of abuse such as cocaine, where the babies are at risk for having in utero MIs if the mom takes a lot of cocaine during the pregnancy. Typically, babies present very smoothly, normal pregnancy, normal labor, normal delivery. Today, in 2023, the majority of moms who are pregnant get good pregnancy screening ultrasounds. And the ultrasonographers are becoming better at picking up structural heart disease. So the majority of congenital heart disease now is picked up in utero. But in some of our regions, especially in the rural areas where they don't have access to MFM and level 3 ultrasounds, we are still seeing undiagnosed congenital heart disease presenting in the newborn period. These babies typically present from birth to about 1 week of age as the PDA starts to close. Their presentation is typically cyanosis that doesn't improve when you give them oxygen. They also may have no other obvious anomalies. But if they do have characteristic findings, we're going to talk about what would general appearance, what would you look at that you would think this baby may have heart disease. Respiratory rate and effort, color, murmur, and perfusion. So we'll talk all about these things to what would clue you in specifically to congenital heart disease. So general appearance. Number one, is the newborn comfortable or is he in distress? And by distress, we mean not just tachypnic, because typically these babies are all tachypnic, but is he grunting, flaring, and retracting? Is he lethargic? Or is he lying there quite comfortable, breathing fast, but really not having any other issues? Is the newborn active or is he lethargic? Is the baby AGA? Are there other anomalies that may clue you in to congenital heart disease, such as midline lesions? The eyes are very narrow. There's a cleft lip and palate. There's micrognathia, something that suggests that there's a lot of midline stuff going on. Is the baby an LGA baby, such as an infant of a diabetic mom? Is the baby small for gestational age, which could clue you into congenital infection or chromosomal problems? And is the baby diaphoretic? Typically, babies do not sweat. So if you see a baby that's diaphoretic, think congestive heart failure until you can rule that out. Now, ruling it out doesn't mean call for a stat echo, but a good physical exam. Is there hepatosplenomegaly? Is there edema? Is the heart large on X-ray? Do you hear a gallop when you listen? Respiratory rate and effort. Most babies with congenital heart disease present with tachypnea without respiratory distress. And the reason is because they're cyanotic, they have tissue hypoxia. And their tissue flips from aerobic metabolism to anaerobic metabolism. Remember that the end product of anaerobic metabolism is lactic acid. And that lactic acid causes a metabolic acidosis as their lactic acid levels rise. The compensation for lactic acidosis is a respiratory alkalosis, and the babies want to blow off CO2. So that tachypnea is secondary to blowing off CO2. However, they typically have healthy lungs. So they are not grunting, flaring, or retracting because they are able to establish adequate tidal volume, and therefore they just increase their respiratory rate to blow off that extra CO2. However, if they have tachypnea with respiratory distress, either they have concurrent respiratory disease or they have an unrelenting metabolic acidosis. So in other words, despite the fact they're trying to compensate, they're making more and more acid. And in an acidotic environment, the heart doesn't function well. So not only do you have structural heart disease, you now start developing functional heart disease where your cardiac contractility decreases and your cardiac output starts to fall. And then thirdly, these babies could become exhausted. It is hard work blowing off CO2, and eventually they just start running out of ATP and their respiratory rate starts to slow down, and therefore their CO2 starts to rise. These babies are all cyanotic. Remember, that's how they presented. So the degree of cyanosis is usually apparent that these babies look blue when their SAT becomes less than 85. And that's because they have about 3 to 5 grams of unsaturated hemoglobin. So if a typical baby is born with a hemoglobin of about 20 and they have a SAT of 85%, that means their unsaturated hemoglobin is about 15%. And 15% of 20 is about 3 grams of hemoglobin. So if you've got 3 grams of unsaturated hemoglobin, you will look blue. If the baby's polycythemic, they will look blue with a higher SAT. And if they're very anemic, it may take a very low SAT before they'll look cyanotic. So when you're interpreting your saturations, it's really important that you know what the baby's hemoglobin is as well. You need to look at the cyanosis. How's it distributed? Is the baby cyanotic in the upper extremities and the lower extremities, or just one or the other? Is the cyanosis central, which is typically structural heart disease, or is it peripheral or acrocyanosis, which may be a circulatory issue and normal? Typically, if we see cyanosis, the babies must have a right to left shunt. By right to left, I mean unoxygenated blood is going over to the oxygenated side of the circulation without becoming oxygenated in the lungs. So it comes back to the heart, it either crosses the foramen or crosses a ventricular septal defect or crosses at the PDA level. One of those 3 places, it goes across to the body without going to the lungs first. If the baby looks very pale, either the baby is very anemic or we see it in vasoconstriction as the babies are going into circulatory shock. And if they jaundiced, we can see prolonged physiologic jaundice in certain types of heart disease, either severe congestive heart failure or in hypothyroidism, which of course is associated with pulmonary stenosis. I'm pretty far into our physical findings at this point when the subject of murmur comes up. So murmurs are only useful if they are there. In the newborn exam, S1 is always normal. Now remember, S1 is closure of the tricuspid and mitral valve. But even if they're missing a tricuspid or a mitral valve, S1 will always sound normal. So the focus really is on S2. This is closure of the pulmonary and the aortic valves. It should be loud and single. That means that the pulmonary and aortic valve should close at the same time because the pressures in the lung should equal the pressures in the body. All babies are born with pulmonary hypertension. If the second heart sound is splitting, that would be abnormal in the delivery room. But if you start hearing a split heart sound by 2 to 3 days of age, that would be physiologic because the pulmonary pressures have come down. However, if the second heart sound is soft and single, that suggests that instead of 2 valves closing, because it is softer, only 1 valve is audible. And that suggests that either the aortic valve is atretic or the pulmonary valve is atretic. A murmur at birth is very uncommon. The most common reason that we hear a murmur at birth physiologically is a baby that was stressed in utero and is born with some cardiac dysfunction and has tricuspid regurgitation. If you hear a murmur at birth and you suspect structural heart disease, it is usually from valvular stenosis, pulmonary stenosis or aortic stenosis. VSDs are typically silent at birth, or if there's right to left flow across the VSD, there's usually not enough of a gradient to cause a murmur either, so those are silent as well. The most important thing from this slide is not what a murmur sounds like with heart disease, but that if you do not have a murmur, that should not be reassuring and does not rule out heart disease, because most of the most severe heart disease, total anomalous pulmonary veins, hyperplastic left heart, pulmonary atresia, they all present in the delivery room or in the first day of life with no heart murmur. So the lack of a murmur does not rule out heart disease, but the presence of a murmur in the delivery room may guide you in that direction. Perfusion should be 2 to 3 seconds. Blood pressure mean typically should be above gestational age. When you're feeling peripheral pulses, evaluate both your upper and your lower pulses. Look for bounding pulses. If your pulses are very bounding, you'll have what's called diastolic runoff or flow during diastole, left to right, and that you'll get across a PDA, aortic regurgitation, or an AV fistula. They all give you a very similar exam. Weak or absent femoral pulses, think about a coarctation. And remember that if you have femoral pulses at birth, because you still have a wide open PDA, that does not rule out a coarctation. So absence of femoral pulses, useful. Presence of femoral pulses, not very helpful. After you've examined the baby, you typically will ask for a chest x-ray. This is a blue baby. You're putting a SAT monitor on, you're ordering a chest x-ray, and then we're going to get blood gas in a moment as well. So when we look at a chest x-ray, what we look at is 2 things. We evaluate the lungs and we evaluate the heart. A normal heart size should be less than 60% of the chest, and cardiomegaly is considered if it's greater than 60% of the chest. For those of you who do pediatric and adult transport, in the teenagers and adults, usually we say 50% of the size of the chest, but because neonates are born with their right ventricle, the predominant ventricle in utero, their heart looks a little bit bigger, so more than 60% of the chest would be considered cardiomegaly. When we assess pulmonary blood flow, what we're looking at is pulmonary vascular markings. So as you can see on this slide, these little white lines over here are what we're looking at. Typically, we see more markings over here at the hilar on the inner side of the lungs. And as you look out towards the edge of the lungs, the markings should get thinner and thinner, where there's more alveoli out here, so more air and less vessels, and bigger vessels over here, easier to see in the hilar areas. When we look at this lung over here, you can see that we see almost no vasculature, either in the hilar area, and the lungs look very, very black. Lots of air, not very much flow. So this would be considered decreased vascular markings. And when we look at this x-ray, you can see that these little white lines seem to run all the way out to the periphery. And even though there's lots of air in the lungs, there seems to be lots of flow as well. So this would be considered increased vascular markings. So now for the next series of x-rays, what I'm going to do is give you an opportunity to look at this x-ray and decide what you think is going on. So let's start with heart size. Do you think this baby has a large heart, a normal heart? In cardiology, we don't really look at this as a small heart. Hearts are usually normal or large. So this baby, definitely less than 60% of the chest, it would be considered normal. Next, we look at lung perfusion. We can definitely see good vasculature here and perhaps a little bit of excess vasculature going out here. So if anything, it would be normal, maybe to a little increased flow. So then what's our differential diagnosis? Well, normal heart, normal perfusion, probably a normal lung. Or if there's slightly increased vasculature, that means slightly increased lung flow, blood flow going to the lungs. So a left to right shunt, so increased pulmonary blood flow through an atrial septal defect, a ventricular septal defect, or at the PDA level. But because the heart is small and pulmonary vasculature is not increased, the baby is not in congestive heart failure. And this baby really should not be cyanotic and should not look very sick to you at all. Let's take a look at this x-ray. Anything jump out at you here? Well, first of all, let's look at heart size. More than 60% or less? Well, this heart is filling up almost the entire left chest, and it's spilling out into the right side as well. So this baby has cardiomegaly. How about lung perfusion? We're certainly seeing a lot of vasculature in the hilar area. And if you can see as you're looking out here, there seems to be a lot of flow out into the periphery as well. So lung perfusion is increased. So what would our differential diagnosis be? So we clearly have lots of flow to the lungs. So either this is from a left to right shunt in congestive heart failure. So there's excess blood flow at the atrial level, excess blood flow at the ventricular level, or excess blood flow at the ductal level. Now, that doesn't mean that's the only thing going on with the baby. You've then got to go and look at the baby. If the baby is well perfused, then his left side has adequate cardiac output, and he probably has congestive heart failure from an ASD, a VSD, or a PDA. However, if the baby is very poorly perfused, especially in the neonatal period, that would suggest that there isn't good cardiac output. So this baby possibly has left ventricular outflow tract obstruction and has a variation of hyperplastic left, such as mitral stenosis, aortic stenosis, or coarctation, where blood can't get out to the body adequately and is all being pushed to the lungs. So looking at the x-ray alone gives you some information, but you then have to go and put that in the context of what the baby looks like. Let's take a look at this x-ray. Over here, let's start with heart size. The thing that should jump out at you is that this heart fills not only the entire left chest, but it's filling almost the entire right chest as well. This is massive cardiomegaly. Lung perfusion, difficult to assess. It looks like over here, there's lots of air, not terrible perfusion. But up here, it looks like maybe there is a little increased perfusion. But I would say overall, it's just difficult to assess. But if you had to guess, you'd probably guess a little increased. So what's your differential diagnosis? Well, if you ever see a heart that fills the entire chest like this, looks like someone shoved a basketball into the baby's chest, almost every time your differential diagnosis will be a left to right shunt and Epstein's anomaly. Now, Epstein's anomaly is when the tricuspid valve drops down into the right ventricle, and the right ventricle becomes very small. But the right atrium is partly right atrium and partly the upper part of the right ventricle. And we call that atrialization of the right ventricle. And as a result, what happens is when the ventricle contracts, that's when the atrium is supposed to fill. But if part of the atrium is the right ventricle, then during systole, when the right ventricle contracts, that part of the right ventricle contracts as well. And it doesn't allow the right atrium to fill completely. And it pushes blood backwards into the body. So that the next diastole, the heart starts to dilate. And what happens is the right atrium gets bigger and bigger and bigger. And what we're seeing over here in this X-ray is mostly right atrium with a small right ventricle and then a dilated heart on the left side as well, as most of the heart crosses the right atrium to the left atrium, and very little goes to the lungs. This is a baby that looks like this is really a very, very sick baby and needs immediate intervention. Finally, let's look at this X-ray. What strikes you over here? Let's start with heart size. Heart is filling the left chest, and it's well over half of the right chest as well. So this is a baby, cardiomegaly. And if you look at the shape of the heart, this is a classic, what we call boot-shaped, where here you can see the leg, the heel, and the front of the boot over here. And a boot-shaped heart should make you think about a few things. So secondly, we're going to look at lung perfusion. And as you can see, the lungs are very dark. We're not seeing a lot of vasculature going out there. So lung perfusion here is decreased. So that tells us with our differential diagnosis is that we have insufficient pulmonary blood flow. So that means all the blood is going to the body and not enough is going to the lungs. So that it means if all the blood's going to the body, there's a right to left shunt. And that comes from tetralogy of Fallot with pulmonary stenosis or atresia, so obstruction at the pulmonary level or obstruction at the tricuspid level. So tricuspid atresia and pulmonary atresia will both give you this type of heart where the left ventricle has been pushed out like this, and this boot-shaped heart with very dark lungs. As you're looking at the X-ray, the other thing you're going to look at is the position of where the heart is and the stomach bubble. A typical X-ray, let's just go back one. As typical X-ray the heart should point to the left side and the stomach bubble should sit on the left side. So we should have what we call levocardia with normal situs, which is the bubble on the left side. Here we have dextrocardia, where the heart is pointing to the right side, but the stomach bubble remains on the left side. So that there's dextrocardia or situs inversus in the chest, but situs solitus in the abdomen. And when you have this sort of discordance, where the apex is pointed to the right, but the stomach bubble is on the left, when you discordant like that, your incidence of congenital heart disease is about 95%. So this X-ray alone should make you very, very suspicious that this baby has significant heart disease. Whereas this baby over here has dextrocardia, but the stomach bubble is actually on the right side. So this baby has situs inversus in the thorax and situs inversus in the abdomen. So this baby has total situs inversus and is an actual mirror image of a normal baby. And as a result, the risk of congenital heart disease is the same as the general population and is therefore quite unlikely. It's when you have discordance that the risk of heart disease goes up. But when you've got concordance, the risk is the same in the general population. As you've got your chest X-ray, you'll get a blood gas as well. And remember that when you get blood gases, know, have you pulled it arterially from a radial stick or an umbilical arterial line? Is it a capillary stick or is it a venous draw? When you evaluate the pH, your golden standard, of course, is arterial blood gas. Capillary, if you've got a nice, good blood flow from the capillaries, your pH should be accurate. And with a venous blood gas, your pH should be lower. Remember that if you've got a very poorly perfused baby, your capillary blood gas is not going to be very accurate. Your PO2 with an arterial gas, that's your gold standard. capillary is variable and venous will be lower and variable as well. So if you're doing capillary or venous blood gases, do not look at your PO2, look at your saturation. CO2 should be accurate with an arterial and a capillary gas, again, as long as your capillary gas is from a well-perfused baby. And your venous gas should be higher because you're taking CO2 back from the cells to the lungs. And then your bicarb is always going to be accurate because it's not a measured value, it's a calculated value in the machine using that Henderson-Hasselbalch equation. If you want to measure the bicarb, then you should get electrolytes on the baby, and the CO2 on your metabolic profile is actually the bicarb. They just call it CO2. So interpreting your blood gas in congenital heart disease, cyanotic congenital heart disease, your blood gas is typically a compensated or partially compensated metabolic acidosis. Your arterial PO2 is usually low. And if your PO2 is extremely low, less than 30, that typically suggests the baby has transposition without a VSD. So there's some findings that really clue you into the exact disease. The chest x-ray I showed you with massive cardiomegaly suggests Epstein's, and a PO2 in the 20s and low 30s suggests transposition without a VSD. If your CO2 is rising despite the metabolic acidosis, then the baby's going into respiratory failure. Either they have concurrent respiratory issues or they're starting to develop congestive heart disease. So be ready to intubate these babies because they are going to become tired and they're going to crash on you very quickly. A lot of these babies have associated arrhythmias with their cyanotic heart disease. And arrhythmias in neonates are relatively straightforward. We can divide them into too fast or too slow. If these babies are too fast, they usually develop high output failure. And this is typically from sinus tachycardia, SVT, atrial flutter, and ventricular tachycardia being the most common. Usually, their heart rate is great. In fact, it's too fast. And because it's too fast, they don't have enough diastolic filling time. So what happens is their tidal volume becomes smaller and smaller, and they develop decreased cardiac output from decreased tidal volume despite having a good heart rate. On the other hand, if their heart rate is too slow, they'll go into what we call low output failure. And this can be from sinus bradycardia or complete heart block. And there's two types of complete heart block. A structurally normal heart, and that's usually from moms that have connective tissue disease, and their antibodies for their connective tissue disease cross the placenta and attack the conduction system. So these babies have great cardiac output, but it's just very slow. Great stroke volume, but it's just very slow so that they have low output from this because they don't have enough tidal volumes. However, once the babies are born, they usually have enough cardiac output to sustain themselves, and they typically have a good outcome. However, if this low heart rate is associated with structural congenital heart disease, then not only do the babies have a very slow heart rate, but they also have sometimes a low tidal volume and typically a right to left shunt, so that they're unable to compensate for their hypoxic state. And these babies have a very high morbidity and mortality and typically come out looking very sick and require pacing in the newborn period. Finally, I'm going to talk about stabilization of the baby with suspected congenital heart disease, and we're going to go through a general approach. So as I've said before, always we start with our ABCs, airway, breathing, and circulation. Put the baby on 100% oxygen until you can get your sats greater than 75. Once your saturations are greater than 75, then typically the cells will go from an anaerobic state to an aerobic state, and you no longer will be in a situation where you're making large amounts of lactic acid. Support ventilation is needed. If the baby's comfortably tachypnic and cyanotic, you don't need to support ventilation. If the baby's in respiratory distress, you will need to support this. Support perfusion with volume with inotropes. Make sure that you're not missing a anemic state, a hypovolemic state. You typically will start with volume and add inotropes to this. Keep in mind that inotropes won't work if you are very acidotic and you're not supporting the baby with oxygen to get them less anaerobic and with ventilation to blow off CO2 to help them bring their pH up. Rule out other causes of cyanosis, as we talked about in the beginning, respiratory causes, hematologic causes. And if all that fails and your SATs are still less than 75%, start prostaglandins. Note, nowhere here have I said get an echo, because if you're out there on transport, your chances of being able to have a stacked echo, unless you carry a point of care ultrasound machine with you, is going to be close to zero. So again, 100% oxygen. If your SATs don't come up, support ventilation. Make sure the babies are getting support for perfusion with volume and inotropes. Make sure you're not missing a pneumothorax, a pneumonia, an effusion, an anemia, other causes of cyanosis. And if that fails, start prostans. So we'll go through each one of these and talk about the best approach to this. Oxygen, everybody uses this very freely. But remember, it's a drug. Use it with respect. Use only enough oxygen to get your SAT 75 to 85% so that you can get rid of anaerobic metabolism. Keep in mind it's a pulmonary vasodilator. So if you suspect that this baby may have hyperplastic left heart, and the way you'd suspect this is that you have a baby that has extremely congested lungs, lots of increased perfusion. He's very cyanotic and he's peripherally very poorly perfused. Putting that baby on tons of oxygen as a pulmonary vasodilator is only going to make him worse. Oxygen, excessive amounts, is a stimulus for the PDA to close. So considering that many of these lesions are ductal dependent, this could hurt you as well. At high oxygen, we know the effects of hyperoxia causing both brain damage and cardiac damage from superoxides and their effect on the tissues. Oxygen saturation reflects tissue oxygenation and doesn't correlate with PO2. For example, in you or me as an adult, if our SATs are 95%, or if, let's say our SATs are 85%, we can easily go to a nomogram and see what our PO2 would be. But in neonates, because of fetal hemoglobin, a SAT of 85 could correlate with a PO2 of 70 if they had mostly adult hemoglobin, or something as low as 40 if they have mostly fetal hemoglobin. So it really isn't that important what their PO2 is. What we want to know is how saturated their hemoglobin is, because that's what's delivering oxygen to the tissues. Keep in mind that you may want to do concurrent monitoring of both the upper and lower extremities to help detect a coarctation. But you can be easily confused with pulmonary hypertension, because pulmonary hypertension can also shunt across the atrial level and across the ductal level. And if it's mostly across the ductal level, you can still see differential cyanosis between upper and lower extremities, and it could be secondary to hypertension and not coarctation. Start with fluids if the baby's poorly perfused or has evidence of shock. Normal saline has shown to be extremely useful in these situations, but if necessary, you can go to albumin if you suspect that colloid may be better. Remember that glucose is important. Hypoglycemia can be very contributory to making these babies worse. Stress causes epinephrine release, which increases utilization of glucose. And anaerobic metabolism uses way more glucose than aerobic metabolism to produce enough energy. Because the babies are on anaerobic metabolism, they are not using the Krebs cycle or the citric acid cycle, which is used through aerobic metabolism, which produces huge amounts of ATP for each molecule of glucose. Therefore, to produce the same amount of ATP, they have to consume massive amounts of glucose anaerobically, or else they're going to start having dysfunction of cardiac muscle and all the other organs. So make sure that you monitor glucose closely and that you provide adequate amounts of glucose. If you don't have enough oxygen carrying capacity, you are not going to be able to get enough oxygen to the tissues. So check your hemoglobin so that you can anticipate needing packed red cells if necessary. And if there's evidence of other organ dysfunction, such as DIC from hepatic injury, bone marrow injury, be ready to go with fresh frozen plasma or cryoprecipitate as needed. If you're going to use prostaglandins, understand that the purpose is to open the PDA if a ductal-dependent lesion is suspected. Now, there's two types of ductal-dependent lesions, either those that will then supply oxygen to the lungs. So that means there's right-sided obstructive lesions, either pulmonary atresia or tricuspid atresia. So keeping the ductus open allows blood to get into the lungs, or a ductus that's dependent to get blood to the body. So the left-sided obstructive lesions, mitral stenosis, aortic issues, or aortic arch issues, so that blood can get to the lungs, but the ductus has to be open for blood to get out to the body. You can initiate prostaglandins before you have a definitive diagnosis, especially if the saturations don't increase despite 100% oxygen, effective ventilation, fluids, inotropes, and ruling out other causes of cyanosis. There is no downside to opening the ductus if the baby does not have congenital heart disease. So if you are wrong and there's another reason for the cyanosis and you open or keep the ductus open inadvertently or wrongly, the baby will not be harmed by this. If you're going to use prostaglandins, make sure you have a secure IV, preferably place a UVC. If you cannot get one in, but you have a UAC in, prostaglandins is actually one of the drugs that you can give through a UAC in extreme circumstances. If you're going to use prostaglandins without a definitive diagnosis, you do need to be aware of the side effects. Apnea, probably the most severe side effect. So be prepared to ventilate if you're starting prostaglandins before you're getting into the ambulance or the helicopter. Doesn't mean you need to intubate, but be prepared to ventilate non-invasively, or if you're going to be in a situation where you will not be able to ventilate non-invasively effectively, then you may want to consider putting an endotracheal tube in before you leave the stable place of the referring facility. Babies could also develop fever with the initiation of prostaglandins, and then that confuses the situation. Could you be missing possible sepsis? So the majority of these babies get started on antibiotics as well. Prostaglandins are vasodilator, so the baby can become hypotensive, so have volume and inotropes ready. It can cause flushing in the babies, it can cause seizures, and it can cause hypocalcemia and platelet dysfunction. So be aware of all these side effects so that you can anticipate them and treat them appropriately if they should occur. If you go to pick up a baby that's been on prostaglandins for over 24 hours, the risk of these side effects are much lower. Consider intubating. If you have impending respiratory failure, you don't want to get into trouble on transport. Put in a good airway and have a secure airway when you're going back. If you have a high suspicion of hypoplastic left heart, and again, to review briefly, large heart, overperfusion of the lungs, very poor perfusion of the baby. The goal is to underventilate, to create an acidosis so that you have an increased pulmonary vascular resistance to force more blood from the lungs to the body. So not only will you start Prostin, but you also want to get blood out of the lungs and out to the body. So you may want to intubate to hyperventilate. If you're starting prostaglandins, think about intubating, especially if you've just initiated the prostaglandins and you have a long way to transport. So finally, there's a couple of special transport issues that I want to emphasize. It is better to start prostaglandins if you're unsure than have the PDA close on transport in an ambulance or a helicopter where you are unable to have effective intervention. If you do have a baby that is that sick that requires prostaglandins, make sure that you have a UVC in place, or if you cannot get a UVC in, then at least 2 PIVs, because you have 2 life-sustaining medications going. One is your prostaglandins, and the other one is glucose, because without glucose, you won't have any ATP production. And you need to have a backup IV in case one of them should infiltrate on transport. Limit your use of oxygen to as much as necessary to prevent a metabolic acidosis. As long as your SATs are greater than 75% and the baby is not in respiratory distress, that is acceptable. Finally, take your time. As I said in the beginning, we are bringing the ICU to the baby. Our goal is not to get the baby out of there and back to our NICU as fast as possible. Our goal is to get the baby out of there and back to the NICU as safely as possible, and make sure that we are giving the optimal care on the road. Make sure you have a secure airway and have good and redundant IV access in place before getting on the road. Don't be shy about asking for help, either at the local facility, if you need help there with X-ray ordering, blood gas running, and calling back to your transport control. We've got lots of resources available to us. We can share X-rays, we can share with iPads and FaceTime and things like that. You can share physical exam findings, communicate, get help, make sure you're doing the best you can for the baby. These are a list of the references that will be available if you'd like to see any of them. And thank you all for listening to this talk. And I'm now going to be available for questions. Thank you.
Hey, Howard. Can you hear me?
Hey, Rob.
How's my favorite South African doing?
You're only South African. He's doing good.
Well, thank you so much for doing this. Already on the chat room, everyone's commented how excellent this was and how much they thoroughly enjoyed it. I do know that when it comes to cardiology, it's a big consternation for a lot of folks. Everybody hears a murmur and immediately they think the worst, and or they see a child that's profoundly cyanotic and they think the worst. And so I think this talk does an excellent job of helping people to get a better grasp as far as what's really going on, and also gives them a wonderful roadmap to diagnosing or at least making the right decisions, like you said.
Thank you. I hope something like this gives them a framework of a approach to take to evaluating these babies. Although most of these babies are diagnosed prenatally, we still see those that sneak in that are completely missed, that we can make all the difference about saving their lives.
Have you noticed an uptick in babies that were not diagnosed in utero since the age of COVID, knowing that folks have gone to home births and such?
I think prenatal care has shifted somewhat, and we've seen a couple of unsuspected fetal anomalies that typically would have been picked up. Have you guys seen the same thing?
Well, just recently we had several gastroschisis babies that nobody knew that came in. That was just one example.
Yeah.
So, and then another one was an RH disease that probably would have done better had they gotten the RhoGAM. So, well, let's move on towards the future. One of the technologies that's come out that folks are looking more and more into the NICU is using portable ultrasound devices for placing IVs and things like that. Have you seen anything in regards to that and to helping folks make a better decision tree as far as how they treat the patient with congenital heart disease?
Yeah, I think point of care ultrasound is really gaining traction in the NICU. For those of us who've been doing this for too many decades, I'm very comfortable with the cardiac echo, but when it comes to head and renal and bladder, I'm back to square one. And also lung ultrasound has become quite popular. So we are actually in the position now of acquiring a point of care ultrasound, and then we're going to start training everybody on how to get the standard views for each one of those organ systems, where I think it can impact our at the bedside decision making. The next step, I guess, would be getting something portable enough to take on the transport with us. I am not aware of any transport teams at this time that take a point of care ultrasound with them. I think we do a pretty good job at the bedside stabilizing the babies, getting them back to the NICU. Between x-ray and between blood gases and our physical exam, we have a pretty good idea that there's heart disease. The echo is going to tell us what it specifically it is and all the details. I'm not sure that we actually need to use that out in the region. Same thing with peripheral IVs. I think in a peds team or an adult team, IV ultrasound placement will really improve things. But neonates, our umbilical vessels are typically pretty straightforward to cannulate. So I think we do well there. However, as technology grows, I'm sure it's only a matter of time before you'll be teaching a point of care ultrasound class for transport personnel.
I guess along those lines, as we try to get more and more information about the pregnancy, some of our folks from the high-risk pregnancy transport teams asked, how common is it to hear a murmur during electronic fetal monitoring or external fetal monitoring in the pregnant patient?
What a great question. I actually have never heard an obstetrician or a MFM specialist talk about, we think there's a murmur. There are other signs of flow abnormalities. For example, flow acceleration can be seen on Doppler, and they can see stenosis, they can see different flow patterns. But as far as fetal monitoring goes, audibly, I've never heard anyone describe a murmur. So great question, and I don't know the answer. I would assume since no one's ever talked about it, it's probably not possible to do. But how interesting.
Yeah. You mentioned amphetamine use been associated with VSDs in transposition. Does that include methamphetamines as well?
Yes, it's all in the same class. And again, those sort of lesions would occur if the exposure's in the first trimester.
First trimester.
Because once you've passed the first trimester, transposition's already there or not, and VSDs are pretty much committed as well, except for the small little ones that are part of development. Later use of it really is more a functional problem than it is a structural problem.
What about anti-anxiety meds? Obviously we're seeing an awful lot of those these days. And if you go to drugs in pregnancy, they're all being ranked as, may cause harm, but we don't know, for lack of a better description.
Yeah, so at this time, most of those over-the-counter, well, not over-the-counter, most of the anti-anxiety, antidepressant meds, although they have some postnatal side effects and we see some sort of withdrawal in the babies from them, I'm not aware of any especially structural heart disease that has been described with these meds.
Yeah. I'm going to change just a little bit here on you. So, in this day and age of transport and hospital administrations, looking at their transport teams to bring more and more patients in, we do know that there are centers of excellence for congenital heart disease, especially those that require immediate or urgent surgeries. And so do you have any approach in regards to the transport teams out there that when they go out in the field and then they have a high suspicion for congenital heart disease, what they may or should be doing in regards to redirecting the care for that child to a different institution?
Right, and that doesn't only hold up for congenital heart disease. There's other things like babies that may need ECMO. If you are in a neonatal intensive care unit, a level 3, which is the majority of our NICUs, where we don't do heart surgery or ECMO, or actually dialysis either, because peritoneal some places do, but hemodialysis much more complex. So if we out in the region and our team calls us and says, this is what we think going on, and we think this is for example, there's certain lesions like transposition with no VSD. Those kids are comfortable looking and their PO2s are in the 30s. They are going to need a balloon atrial septostomy in addition to their prostate. There's no point in coming to our hospital. We don't do those, and we will call in our region, University of Michigan or Nationwide are our two major referral centers, and we'll call them, and whichever one has space for them, the ambulance goes from the referring hospital, or the helicopter will fly from the referring hospital straight to the level 3 center. If we've got a baby out there that's intubated on nitric and we are still on 100% oxygen and struggling, we will do the same thing. We need to get the patient to the correct place for the correct therapy.
Absolutely correct. I think that's the ethical thing to do for sure.
Yeah.
Absolutely. Does anybody in the audience have any questions at all for Dr. Stein? All right. Howard, always a pleasure. I'm sorry we didn't get together last year. Hopefully this year will be the year. It's probably the first time in 15 years that we haven't gotten together, but
I know.
But I hope everything's well, and thank you so much. Tell Damar said hello as well.
And thank you for including me in this. Anything that you run is always of the highest quality, and I'm just honored to be part of it. So
God bless you. Thank you, Howard. Appreciate it.
Bye-bye.
All right, folks. That'll conclude the pre-conference, Hot Topics in Transport Medicine. Again, this will be available for up to a year, where you can download it or stream it, watch it with your transport teams. Again, they won't be able to get any kind of CE or CME. As far as the sign-in, don't forget the sign-in. If you didn't get a signed in, that's very important if you want to get your CE or CME. Tomorrow morning, you'll be able to start signing in after about 8:30. And Dr. Chris Stapley will be taking over as the moderator for the 11th Annual Neonatal Symposium. And we've got some wonderful speakers set up for you tomorrow, and that'll begin promptly at 9 o'clock. So until then, stay safe.
I took each word she said as